Good morning and welcome everyone to the fifth meeting of the Health and Sport Committee in 2013. And as usual at this point, can I remind those present to switch off all mobile phones, Blackberries and other wireless devices, as they often interfere with our sound system. Our first agenda item today is to decide whether to take item number 3 in private, which is our work programme, which also includes an approach paper, which we would normally take in private. Can I have the committee's agreement that we take item number 3 in private? Thank you. The second item on our agenda today is a roundtable evidence session as part of an inquiry into teenage pregnancy. And can I welcome all of the contributors to the panel today. It's useful, I think, if we go around and introduce ourselves. My name is Duncan McNeill. I'm the MSP for Greenock and Inverclyde and convener of the Health and Sport Committee.
Okay, I'm Tracy Stewart. I'm a Quality Improvement Officer within the Education Department of Dundee City Council, and I also have a corporate role in sexual health.
Hi, I'm Bob Doris, MSP for Glasgow, and I'm also Deputy Convener of the committee.
Hello, I'm Marion Flynn. I'm a Strategic Manager for Young People's Sexual Health in Glasgow.
Gil Patterson, Member for Clydebank and Mulgai.
Robert Naylor, Director of Education and Leisure Services in Renfrewshire Council and the Corporate Lead for Sexual Health.
Mark MacDonald, MSP for North East Scotland.
Kath King, Health Improvement Policy Manager for Highland Council, working in the Health and Social Care Service, but working very closely with the Education Service as well.
Annette Milne, MSP for North East Scotland.
Bruce Smith, Member for Glasgow.
Derek Allen, Rector of Kirkcaldy High School.
David Torrance, MSP, Kirkcaldy Constituency.
I'm Brian Kirkcaldy, Head of Service, Education Service, Fife Council.
Aileen MacLeod, MSP for the South of Scotland.
Richard Simpson, MSP, Mid-Scotland and Fife.
Thank you all very much for that. Our first question this morning, just to get us started, is from Dave Torrance.
Thank you, Convener, and good morning, everybody. It's relevant to Derek Allen and Brian Kirkcaldy. Kirkcaldy High School is running a pilot project with condom dispensing and pregnancy testing. I'm just wondering how that impact is having on an area which has 12.3% under 16 teenage pregnancy, the highest in Europe, and what effect and results that is having, and is the data up to date for it, and the data sharing, how it's across the services?
Yes, thank you.
Thank you, Convener. Kirkcaldy High School is one of a number of schools in Fife where we have offered targeted support because of the rate of reported teenage pregnancy. And what we're doing with targeted schools is we're trying a number of interventions in terms of prevention and targeted prevention, and we're hopeful that these will have an effect. And one of the challenges in terms of the data is that the data that's available to us is always lagging. It's always something like 2 years out of date. And it would be most helpful for us if we could find a way of having a more responsive data feedback system. And one of the things we'd like to explore with colleagues in the NHS and nationally would be whether we can find some techniques for sharing data more frequently and more quickly.
Anyone else?
Yep, in particular reference to the Kirkcaldy High School pilot, I would agree with Brian Kirkcaldy that certainly it's a multifaceted issue, and it doesn't just turn on the provision of condoms in school or a pregnancy testing service. So these are part of a kind of broader strategy we have to tackle issues of self-esteem among girls and to join up services. It's based on particularly strong partnership working with the local healthcare people, the health service people, the Kirkcaldy and Leavenmouth community healthcare people. The school nurse service in particular have been very proactive in supporting our teaching staff to deliver a strong message to young people that it is possible to avoid this scenario. And it's underpinned by a clear understanding that the evidence points out that discussing matters of sexuality and sexual health does not encourage promiscuity or early adoption of sexual behaviours. Quite the opposite, in fact. So it's underpinned by that. That's quite important, I think, as well. In terms of the data, anecdotally, it does appear to be having some impact within our school community. And we'll wait to see the latest data for Kirkcaldy shortly.
Okay. Does anyone else, you're just on Dave's initial question about the targeting of a particular area or a school, is there anyone else that uses that? No one else, why not?
I can maybe come in there in Dundee, although we don't have the same level of service provision, i.e. issuing condoms, we do have generic health drop-ins in all our secondary schools. And more recently, looking at much more targeted groups of young people in our off-site provisions. That's come about through very strong partnership with our colleagues in health and the voluntary sector, and very strong signposting to local sexual health services.
Dave, yes?
Just a quick question to follow up. How many pupils are actually using the service? Do you have the data for?
There's data available for the pilot which relates to August to October 2012 in Kirkcaldy High School with a population of approximately 1,100 pupils. 45 females and 33 males referred to the drop-in. All third-year pupils were targeted with single-sex, small group workshop sessions on relationships and safe sex, safer sex, and other relevant matters. Sex and the law was one of the other themes as well. The drop-ins were well used. In terms of condom distribution, 373 condoms were issued to the females and 252 in total to males. And this was done without a great deal of fuss across the school, quite frankly. We didn't find them lying in the corridors, as some people had worried about, that it would be done in a way which was not appropriate. As I say, the strong partnership working and the strong support of our school nurse team really underpinned this. They were trusted within our community as well. And as Tracy Stewart has said, the contextualisation within wider health issues was really mattered to that particular programme.
Yes, I was just wanting to see if Dave was coming back. Right, thanks, Dave. Mark?
Following on from that, I wonder what your views and maybe the wider views of our panel are on the buy-in from parents to what you're doing in Kirkcaldy, and also what's being done in terms of the wider sexual health strategy, because obviously the school is only responsible for the children for a part of the day, and the same goes for any other public sector service. At the end of the day, the majority of the children's time, they are the responsibility of their parents, and obviously their parents' attitudes, behaviours will have a direct impact on the child's attitudes and behaviours. So I just wonder what effort is being made to engage parents in this process as well as the children, because obviously they have an absolutely key role to play if we're going to turn around some of the behaviours that we're discussing.
We have done in the past. We've had special focus parents events on sexual education in school, and we intend to do this again with the school nurse team shortly. The service was signposted in a kind of discreet way, in a subtle way, if you like, to parents, because the last thing we wanted to was to inflame any unnecessary kind of reaction, quite honestly. We were very careful about the launch of the service, describing it as an enhanced service and inviting parents to find out more about it. But you're right, it's to be sensitively handled, and the next stage is to have a special parents' evening later this spring. It'll be organised probably in conjunction with our own parent council, who are fully aware of the programme which we offer.
And just to follow up on that.
Well, Mark,
yeah, sure.
To your first question, because Marianne indicated she would wish to come in, so of course we'll broaden it out.
Just to say, really, I suppose in Glasgow we've put a great emphasis on involving parents in this. From the outset, we did a consultation with parents where we asked them what they thought of sexual health and relationships, both what they had received themselves and also what they wanted for their own children. And from that, we have used that information to both create a dedicated service called Talk To, which specifically aims to encourage parents to talk with their children from a very early stage about growing up and puberty and sexual health matters. And we've been very successful, I would say, in terms of engaging a range of parents across the city into that programme. And I think the good thing about that programme is it has many strands to it. So there's a website, there's a book collection in all Glasgow City Council libraries, but there's also a group work programme. So parents can dip in and out of that as they see fit. And then linked to that in terms of the work that we have done on the sexual health and relationships education programme in schools, there is a strong emphasis on that and encouraging parents to be part and parcel of their children's learning. And I think the thing that we have done in Glasgow is very much try to reframe some of this debate into a more general debate around sexual health and relationships and to place it within children's development. And so within that, we have been able to engage parents, I think, in a very meaningful way because we promote the idea that this is part and parcel of what children need to learn as they're growing up in an age and stage appropriate way.
The level of participation, before I ask anyone else about do parents engage with that process? Very much so. Within the schools programme itself, we have a very active means when we're initially going into schools to implement the new programme that we've developed in Glasgow. We actively try to engage parents by ensuring that the schools have an information evening where parents can come and hear more about the programme and also look at the materials and ask any questions. There is also an information pack goes home to all parents because we realise all parents aren't going to be able to make that information evening. And in addition to that, we have built in, working on the basis of work that was done elsewhere, would have to say we've built in what we call home activity exercises, where children take some work home to discuss it with their parents. And the importance there isn't about getting it right or wrong. It really is about prompting that conversation, because that's what parents said to us, that they want to work in conjunction with schools, but many of them didn't know where to start. And so I think the schools programme gives them that prompt and gives them that ability to get going. Is there any other experience that's similar to that, addressing Mark's initial question? Yes.
Yeah, within Dundee, we've been working with the Speakeasy programme, which is similar to the one that Marion has spoken about, and engaging with parents where our local youth workers or other voluntary sector workers have undergone some significant training and are meeting with parents and going through this accredited pack. And we're now seeing that some of these parents are now coming back, and it's much more of a peer-on-peer model that's been developed.
Mark?
Yeah, it was just to come back, and the convener mentioned about parents engaging, and I think, if I remember from my time as a local councillor attending parent council meetings, the head teachers would always tell you that there is always a core parent group, a percentage of the parents with whom it is difficult to engage or who choose not to engage with the school. And I just wondered if, in this regard, there was any correlation between those parents who maybe were not choosing to engage or were not engaging, and those children who were perhaps more likely to engage in risky sexual behaviours and the kind of sexual behaviours that we're discussing here, if that correlation bears out.
Yes.
Yes. There is a correlation there. One of the groups of young people who are at risk of becoming pregnant in teenage years are children who are engaging in risk-taking behaviour and are not always well supervised in the evenings. And so in addition to what Marion and Tracy have described as a kind of universal approach, which we support and do, within the context of the Getting It Right for Every Child framework, we would expect our multi-agency teams to be intervening with families where there's evidence that the young person is involved in risk-taking or potentially involved in risk-taking behaviour, and that would be associated with alcohol and substance misuse often. And so we're joined up with the voluntary sector, the police and detached youth workers, as well as our family support workers in terms of intervening in those higher risk situations.
In Highland, we do take sexual health and relationships education very seriously, but more seriously than that, we take the GIRFEC approach, which we now call the Highland Practice Model, which means that we work in partnership and identify vulnerable children at a very early stage and hand the responsibility back to their parents. And that's probably as effective in terms of identifying issues at an early age so these young people can be targeted. I think the other issue for us is the role of school nurses as well, in that we know that there's 2 new sets of immunisation coming up shortly, which is going to take up more of their time. And I think that their role within the school setting as well, because often parents and pupils will trust to go and speak to a nurse, but they're very busy on lots of other things. There's almost 2 separate roles for school nurses that are running side by side.
Yes. I
think it would be fair to say that it's often very difficult to engage with the parents of those children that are most vulnerable in terms of forums such as parent councils and so on. The people who tend to come to parent councils tend to be the parents of children that are not in the most vulnerable groups in this regard. So certainly in Renfrewshire, similar to what others have said, it's much more likely to be our multi-agency teams, our home link workers, social workers working on the ground that are identifying children that have likely other risk factor behaviours that are going to be engaging with parents on the whole issue of safe sex and avoiding pregnancy and so on. So that's about local knowledge of what the circumstances are for the individual children and working with the parents and families there. And I think in my experience it's necessary for us to do much more in that regard, and specifically to target communities where we have very high incidences of teenage pregnancy.
Yes, Carl.
Just to add on the GIRFEC approach, what we take very seriously is the named person, so that a child has a named person throughout its life, so that it's the midwife for the very early years, the health visitor, then the primary school head, and then the guidance teacher. And that person should be the person who pulls together the jigsaw of all the aspects of that child's life. So in addition to the wider interventions that are there, that individual approach that ties everything together is really important.
Anyone else? Mark?
Just one final question, Convener, and that's around, obviously Nanette and I had a very enjoyable visit in Dundee, listening to some of the practice that's taking place there and seeing firsthand some of the work that's being done. One of the things that was raised during the discussion was around the role of the father in a teenage pregnancy, and often we focus very much on the mother for obvious reasons, but there is obviously she didn't get pregnant by herself, and there is often a father there. Now, one of the things that we learned in Dundee was that very often the father of the child is not of school age or is not in the school system, but sometimes they are. I'm just wondering what work is done to try and encourage fathers in these situations to have a role in their child's life, because obviously when we get to a stage where a teenage pregnancy occurs and is carried through, we then have to ensure that the very best is done by the child that comes as a result of that pregnancy. And one of the things that will help that child will be if its father has a role in its life. And I just wonder what work is done, firstly to identify who the father is, help identify who the father is, and then also to try and encourage the father to take some responsibilities and to have an involvement in the upbringing of the child.
Does anyone want to take that? Yes, please.
Well, I think as the committee visited the Young Parents Support Base in Glasgow, so there's quite an emphasis, again, within that work of ensuring that we don't talk about it as young mothers. that we do talk about it in terms of young parents, and that we try to engage the father from a very early stage. I think more could be done, definitely, in terms of encouraging fathers to be involved. But what we've found is that where they're there, and they are there for the majority of the cases that we work with through that support base, they do want to be involved, but sometimes that they're sidelined by a series of professionals where the emphasis is very much on the mother.
Any other comments on that? Yes, please, Carol.
Well, we're just introducing the family nurse partnership approach, which should look at the whole family unit, and working with young parents to break that cycle, because often teenage parents are from teenage parents. But I think the other thing that I'd want to add to that is the societal approach to young men. You know, we've rightly focused on women and their view of themselves, but I think young men have maybe been slightly sidelined, and we need to do more work, both nationally and locally, to look at encouraging young men to take nurturing roles. That's kind of absent to a great extent.
No one else? Yes, please.
We also have the family nurse partnership within Dundee, and it's showing some early signs of impact around that. So we are trying to engage with the family unit, but I agree with other comments that have been made, and more work could be done with young fathers. We've used a healthy community collaborative approach within Dundee, and there's early signs there that young fathers have been establishing some support groups, and young parents are coming together to support each other. So we are trying to move things forward, but it's an area that we will focus on.
There's been a number of references to the school nurse and things. Is it, maybe me, too long away from school, but has every secondary school got a school nurse, or do they work across, different schools? Can you explain to me where they are, how they are, and how they a nurse can help here?
I don't know the detail of this, but
we might get some of that.
Certainly, the role of school nursing, I think, has been under review of late, just because of the demands on that service, and there has been discussion about where the emphasis should be, and whether it should be more on things like immunisations, child protection, various elements of that. I think given that there's a very large school estate in Glasgow, I'm not sure that some of the services that have been talked of already, that there's the personnel to work across that. I think some school nurses are involved in health improvement activity within schools, but that's not across the piece in Glasgow.
Is that a similar situation? Yes, Mr.
Yes, each of our secondary schools would have a school nurse assigned to it, and the school nurse would be working in the context of the Children's Services Plan. So in Fife, the Children's Services Plan has as one of its priorities a reduction in teenage pregnancy, so they would be working in the context of that strategic aim.
So is that in collaboration with the Health Board? Do they contribute to that?
The school nurse is employed by the NHS Fife. And
so how many would you have in Fife?
I'm not sure how many school nurses we would
have. But they're not in every school,
in
that's
total. There would be a school nurse assigned to every secondary school in Fife.
Right. Yeah. Yes, please.
Maybe should say that in Highland we have integrated children's services, so we actually employ the school nurses as well, and each school has a school nurse assigned, but the tension is between the health improvement role that they have, the immunisation role, and the child protection. There's a whole raft of things in there that's increasing, and looking at vulnerable children is becoming more of a priority rather than the wider health role.
Yeah. Competing sort of demands there with it. Yeah. Mr. Naylor, will you?
Just to say, the similar picture in Renfrewshire, we do have school nurses that work across the estate, but not individually assigned to a school. And I would echo what's just been said about the role and responsibility of school nurses. They're charged with a great many activities, only one of which would relate to this particular area. And certainly we've had recent discussions about things such as puberty talks, which are no longer carried out by school nurses, which had been practiced hitherto, and there's now development of programmes whereby teachers are taking on that kind of responsibility because school nurses are involved in other areas and are tasked by the Community Health Partnership to do important work in these other areas, but nevertheless the resource is limited, I would suggest.
Mm-hmm. Yes.
I would echo what's been said. We have a school health nurse attached to each of our secondary and their associated primary clusters, and also looked after and accommodated nurses as well. But the competing demands on them has meant in some respects that some of the proactive health promotion work has been kind of put aside, but we are trying to redress that, and we are currently having conversations around that. Our school health nurses would also support each of our secondary school health drop-ins, which are operational in each of our secondary schools, and they happen on a weekly basis.
Mr Allen.
The drop-in service at Kirkcaldy High covers, there's a specific sexual health drop-in every Friday, and other drop-in clinics dotted throughout the term, and other focus weeks as well on different aspects such as teenage mental health, smoking cessation, you know, various things, perhaps diabetes awareness, as well as supporting teachers in delivering health messages, including sexual health, within the curriculum, as part of Curriculum for Excellence. I mentioned this earlier, but it really is the key thing. An effective school nurse service working in partnership with the education people to tackle this whole issue.
It's interesting, we've got another session later with you know, we might raise that again, but I mean, there's been a lot of publicity in the last couple of days about extending that sort of service through school nurses. It would seem there's a big question mark about how you could extend that when there's, it seems to be, maybe I'm getting this wrong, but there seems to be patchy, it seems to be add-on, and there's been 24 hours of publicity about the morning after pill that will be delivered by school nurses as if that's their sole responsibility, as if they are sitting, waiting in the school, can be visited on a daily, hourly basis. You know, on your evidence, that would not be the case. No, Mr Naylor?
That certainly wouldn't be the case. And I mean, as for the media coverage about the morning after pill, were that to be made available in schools, there are a whole range of issues that would need to be considered, not least the issue of denominational, non-denominational schools. But there would need to, in my view, be a very significant reconsideration of the allocation of health resources. If we wanted to have a nurse service dedicated to schools, then that resource would need to come to schools, and we would need to focus very clearly on what it is that we expect to be delivered in terms of the health agenda in schools in that regard.
Anyone else? Would it be desirable, you know, that a nurse would deliver that or be the key person in all of this, or is it different specialities that would? Marianne's wanting to come in, and then Kath as well.
I think that's a very good question. I think that there's an issue about, do young people feel that that is the most appropriate place that they'd wish to get a service? Is it confidential enough? Does it provide them with a level of anonymity that's required? I think there's something, the way that I think it's been approached in Glasgow is to improve the health services that are community-based, and so therefore that young people have access to emergency contraception at easy distance, whether that's through a dedicated sexual health service or through pharmacy provision. So I think there's a difficulty in putting all the eggs in one basket and just saying it's school nurses. I think it needs to be a range of things so that young people feel comfortable approaching services.
But there is a mechanism in place now that young people can be directed at that age group for emergency contraception.
Yes.
That's in place, but not at the school, but it's in place within close proximity to the school.
Yes.
Yeah.
I just wanted to really agree with that comment that I think we shouldn't confuse the administration of emergency contraception with the school nurse role, because I think the school nurse role is as much about good signposting, confidential advice to help young people, and there isn't enough of a resource of that. We would be targeting community pharmacies at areas of deprivation, and also areas where lots of young people are bused to school, because we've got the whole rural issue to think about as well, and how children and young people access services confidentially. So the school nurse is actually really pivotal in terms of that signposting and giving information. And also young people have said in surveys that they actually prefer somebody other than their teacher sometimes giving them those messages.
Okay. Gil Patterson.
That's very appropriate. It's about the messages I was going to talk about. And I think it was Mr. Allen that said that your pilot is for S3 onward. And I wondered if there was any impact or any reaction in a preventative sense on younger pupils, S1, S2, if there's something happening in there as a result of what's happening with the bigger boys and girls.
The universal focus for all pupils to be taught, if you like, sex and relationships education in small single-sex groups supported by the school nurse is focused on third year, but we do have a target group in S1 and 2, mainly of girls actually, who we think are at risk and their families are involved. It's hard to say, but I would imagine, given that this is more widely known across the school population in terms of assemblies which we've delivered to not just year groups, this message. And again, it's been kind of discreetly done, rather than have big banners about availability of condoms or whatever. There's been little cards that have been shared with pupils individually. So the drop-in service has mainly been taken up by third and fourth year. In fact, I don't think I have records if anyone under that particular year group has accessed it. But certainly in terms of changing culture, bringing this to the fore and talking about these matters more openly and having a more proactive and kind of pragmatic approach to things, I think is helping us to tackle the issue.
Is that showing up in any meaningful way?
Well, only anecdotally, actually.
Yeah.
I think over the last 3 years we've had 3 pregnancies which have gone to term in the school, which is fewer than it has been in recent years. But I'd like to see, as Brian said, I'd like to see the figures to see that confirmed.
Yeah, okay. Thanks for that.
Bob Doris.
Thank you. I'm just kind of curious about a link that this has to our health inequalities inquiry that the committee is doing. And one of the things that seems to be emerging from that is preaching to individuals about lifestyle choices tends to be unsuccessful, whether people are 12, 22 or 50. It doesn't seem to work. And the measure that keeps coming through is about empowering people, in this case young people, to make positive choices. So in terms of the delivery of sexual health information and education within schools, does it sit within a designated area, this is the sexual health bit, or is it woven and integrated into wider self-empowerment roles, such as that way you could even start it as early as primary schools, where you talk to young girls about, what your future career choices might be, what the barriers might be to successfully achieving those career choices, depending on whether or not you are a young mother or whatever. Where does the idea of empowerment, because the word self-respect, the phrase self-respect came up, which I thought was very important, where does the sexual health strategy sit within empowering young people to make aspirational choices for their future?
Yes, Mr.
I think that's a very good question, and I would actually frame it slightly more widely even than that, because there is an association between social disadvantage and teenage pregnancy, and part of an education system and a school's responsibility would be to try and raise aspirations and expectations for the whole population of young people, particularly those from more disadvantaged backgrounds. And we think that by improving educational outcomes and by improving life chances through an educational process, we will have an impact on that sense of empowerment that's important in terms of choices that young people make at age 13, 14, 15 about what they do. So that whole approach in terms of the prevention role that education and school services can provide is about raising expectations and aspirations and outcomes. And then within that, discussion about social relationships and health and sex is part of that bigger context. Curriculum for Excellence makes health and well-being a key strand. It's one of the 3 key strands, as you know, for Curriculum for Excellence. And it is now a responsibility for school staff and indeed for parents to be thinking about health and well-being more holistically and to see that in the context of how the child is living and learning.
I would take it even more broadly than that. In Highland, we would view it that any measures to tackle deprivation will actually tackle teenage pregnancy. I think it's as simple as that. We've invested £3 million into preventative work, some of which has gone to tackle deprivation and some of it's gone to early years. And we're now joined up with other local authorities in Scotland on the Early Years Collaborative, so looking at how we can improve those early years interventions so that we're working with young people. So the young people in the next generation, there should be lots of changes. But overall, I would say that measures to tackle deprivation itself will tackle this issue.
Mr. Naylor.
I would simply echo that. I mean, I think health and wellbeing within Curriculum for Excellence and various programmes that will have been devised across local authority areas about relationships, sexual health, parenthood programmes and so on, that are embedded within the curriculum, delivered either discreetly or part of wider personal and social education programmes, do make a difference. They're delivered to all children. However, I think it's clear that the issue of teenage pregnancy is a social demographic issue, probably far more than it's to do with health. And I think what's just been said about targeting approaches to communities where you do have generational cycles of teenage pregnancies and single parent families, unemployment. The way to tackle this is to target resources in a community planning approach where we have all of the agencies working much more closely together with the families of children who are likely to emerge into a risk situation because of what we know about their community, and to work with them really from age 0 all the way through, and be making use of evidence-based programmes, parenting programmes such as Triple P, things like Incredible Years that we've now got some experience of in Renfrewshire, to work with families across the piece, so that by the time children are getting to the age where it's conceivable that they could become pregnant, the inputs and the work that's been done with them is far more likely to have taken them to a place where the suggestion that the way that they can become loved or the way that they can become recognised is to go with a boy or to start having sexual intercourse early is a considerable distance from the radar, which isn't the case at the moment.
Anyone else? Yes, Marianne.
I think the point about not preaching to young people is a really important one. And I think what we've tried to do, particularly in our schools-based programme, it's a very discursive programme that attempts to allow young people to think through the issues and very much develop. We put a great emphasis on developing critical thinking throughout the piece. And I think the one thing that we do, it is a P1 to S6 programme that we work. So I think a lot of that at primary school, it's very much about the building blocks for good sexual health and relationships, where you can talk with young children about friendship, about their rights to their own body and privacy. So all those kind of building blocks that are important for, assertiveness, saying what you want and what you don't want, they can be built in, I think, at a very early age.
Yes.
I would absolutely echo everything that's been said on this up to now. I just perhaps wanted to highlight one approach that we were taking in Dundee through evidence that suggests that involvement in youth development programmes about this continual raising of aspiration and getting a sense of belief about yourself and where you want to go in life. We've introduced what we've called the Health Buddies programme, where we train third-year pupils to deliver aspects of relationships, sexual health and parenthood to their peers in S1. Certainly we are seeing an impact, particularly around those young people who have been trained in the peer education approach, about their raised aspirations and beliefs about themselves for the future.
Yes, Bob, yes, certainly.
Yeah, it was encouraging to hear when Marianne Flynn said it's a P1 onwards programme, and that kind of gave me comfort that it's sexual health is placed in a much wider context. Can I ask about placing it in a wider context? Again, we keep widening things out during this discussion, but in terms of schools seem to be seeking to not preach to young people and empowering them, and that's very positive. For some young people, it's still the school, no matter how wonderful programmes, initiatives are. For some of the most excluded young people, it's still the school. Is there active work going on within communities for working with young people within youth programmes out with the school, with organisations in the voluntary sector, whoever that work with young people, to talk to them and hang out where they are and get the message over, hang out where they are? Because very much school is seen as, for the most excluded young people, school can be seen as alien territory, no matter how well intentioned and well thought out courses are. So as part of the overall sexual health strategies, they're working on via the voluntary sector or youth programmes out with the education service.
Yes, please, Mr.
Yes, we take a partnership approach to this. So our sexual health strategy group at Fife level is comprised of voluntary sector, police, NHS, education, detached youth work, social work and so on. And that's reflected then at local level. There is an issue about the extent to which young people will access drop-in services. And the example that has been described in Kirkcaldy High School is one example, but we have other examples in Fife of our targeted schools where the drop-in service is actually provided near the school but in a community centre. So we listen to young people locally about what they would find accessible, as well as listening to staff and parents about what they would find acceptable. And that means that we've actually got a range of different sources of advice and support.
Anyone else? Yes, go on, thanks.
I suppose just to say, I think it's important, I think, to raise the issue that this isn't just about what happens in schools. And I think we do try, I think, through youth health services and through youth provision in Glasgow to address these issues with young people, but I think it's a gap. And I think it's something that we need to work on within the city.
The gap being?
I think to me there needs to be more targeted programmes that take a youth work approach, that are out with school, that can talk with young people in a meaningful way about what relationships and what friendships mean to them. And look at issues around assertiveness and how young people, I think, are dealing with a very different cultural backdrop than when most of us were growing up. And I think we're not doing that in a sufficiently targeted way at the moment.
Yeah, just perhaps more of a final comment rather than an additional question. I am encouraged with the work that is going on in schools, but the more I work with youth organisations in Glasgow, the more I find out how powerful it is to actually meet young people on their own territory, on their own turf. And as much as we want school to be their territory, for many of the most excluded it's not. And I don't think we can underestimate the good work that is done by youth groups in Glasgow and beyond in terms of building relationships with young people. And once you get that trust, and I know how difficult it can be to get that trust within schools despite all the good work that's going on. So I think I would be keen for us to follow up on what work is happening out with traditional educational routes, but I thank people for their comments.
Yeah,
Can I
please,
just add
yes,
one thing?
yes.
The programme that I had previously mentioned, Health Buddies, I should have emphasised there that that is a joint approach through community learning and development and the health service and education, where we've really seen strong partnership working, which has resulted in young people who have undergone the programme to perhaps go out and do some volunteering work, and as well as that gain accreditation through Youth Achievement Awards, for example. So that's just one example.
Are we hearing, as often we do, unfortunately, that we have got lots of resources here? We've heard about the nurse partnerships, school nurse. We've heard about teaching, especially teachers, sexual health workers, youth workers, all with separate jobs. Where is the partnership that brings all of those people together, maximise the resource, and gets a better outcome than we've currently got on the figures that we have here, where we've got some areas and under 16s which are double the national average with all of these things going on. Now, are we in control? Who's in control of all of these resources that make them go forward in a coherent way? Kath and then Mr. Naylor.
I can't really speak overall for all of the services, but we are really putting a lot of store by the named person approach for the individual child and young person, that person should be able to access the services and highlight when a young person is becoming vulnerable, so that they can signpost them to the services, alert the right services when something happens for each child, and we think that's really important.
And does it happen?
It's in its early stages, but yes, it does happen.
But why have we got some areas in Scotland which is double the national average for under 16? Why have we not moved on that figure when all of this money is being spent and we've got different groups of workers all in the field, all working very hard to prevent that happening? It's not necessary, it's just to everyone. Well, Mr. Naylor, I think, and then Mr. Kirkcaldy. I'll let you back in, of course.
I was just going to say that I'm not sure that every area has the named person approach yet. I think it's in the Children and Young People's Bill, but we've gone ahead with that, so I wouldn't say that everybody has that.
That's helpful, thank you. Yes?
In Renfrewshire, we have a sexual health planning and implementation group that brings together education services, community health partnership, various other agencies, including the voluntary sector, to develop approaches that are consistent and try to make use of the combined resource that we have available to us, which involves also youth workers, community learning and development, and various outreach programmes working directly with children both within and out with school. But I would go back to your question, why would it be that we have certain areas where the rate is double the average? And that's, in my view, because the services that we are seeking to provide are generally provided on a universal basis. What needs to happen, in my view, is that it needs to be much more targeting towards the areas where we see double or sometimes treble the rates that we see in other places. And again, I go back to this being a social issue. This is about deprivation in certain communities where there has been poor modelling behaviour by parents. There's often serious drug and alcohol misuse problems. Children often are unable to access school in the way that we would hope that they can access school. They're often unable to access community resources in the way that we would hope that they could. And the only way that we can tackle that is to develop much more cogent family-centred approaches from the earliest stage and make sure that the resource goes into the communities that we can make the most difference.
I'm very familiar of all of that in my own area. In Inverclyde, where we've got some of the most deprived areas outside Glasgow. And our figure is 6.9 for under 16s. And I don't want to name anybody in particular, but Dundee is 14. More than double. Similar communities, similar, levels of deprivation, you know, and all of this money going in and people working there. How do we as a committee, you know, come to any conclusions about what we should be recommending? And Mr. Kirkconnell.
I would come back to my very initial point about data. We are, since the current national data was published, we've been in Fife very conscious of the place that we occupy in the league table. It's not where we want to be. And that's why we've introduced a whole lot of innovations, a whole lot of more strengthened partnership working at local level. It's in our Children's Services Plan as a priority. We're doing things that we think will make an impact. But at the moment, in terms of the way the data is cycled, the best that this committee has is all that we have, which is the 2010 data. And we'd like to know whether what we've been doing since 2010 is making a difference. More than that, we'd like to know which parts of it are making a difference the most. We want to become more intelligence-led, and we want to see if what we're doing in Kirkcaldy High School, compared with what we're doing in Auchmuty High School, is making a bigger or a lesser difference. So I do think that one of the things that the committee would be well advised to consider would be whether we can get a more responsive data sharing and feedback mechanism, disaggregated ideally to community and school level.
I might come back to that, but Richard Simpson's going to come in because there's some questions about, is the data that we're gathering all that we need? Is this a good guide to what's actually going on, just counting terminations and pregnancies?
Just to make a point,
go ahead,
make a quick point on that. In my visit to Oldham, what was impressive was they've been collecting statistics by school and by locality, and the schools all know what their own rates are, and they know them very quickly, and they've managed to reduce the levels from twice the level of the national average to just below the national average. They're having a problem now, but with flatlining of that, they're not getting further, but they've made a very good start. But one of the things that interests me, and I wonder about, is that, well, there are two bits. One is whether the provision is one of these ones like general practice, where there's a GP for every patient, but actually every patient's needs are somewhat different, and the deprived areas actually need a hell of a lot more than the other areas. So are we distributing the resources on a basis which is not equality, but is equitable? In other words, it meets the real needs that are out there. That's one thing. And the other thing is that specifically the thing about cycling and it continuing through communities, you know, we're pinning all our hopes on the Family Nurse Partnership, and I think it's a good program. I have no criticism of the program itself, but it is very resource intensive. It's very expensive, and I note that in Dundee, just to that the programs such as Baby Bumps and Young Mothers to Be, which were previously available to support young mothers, no longer meet. And the FNP is a much more focused program on a much smaller group. So there's a group, you know, of really very, very problematic families where we may be beginning to tackle the problem. But there's another group beyond that, that if we focus all our resources on the FNP program and we lose things like Baby Bumps and Young Mothers to Be, which are, you know, peer group support for these young mothers, you know, are we not going to run into real problems? So I just wonder as to what people are feeling about that program.
Yeah, perhaps to go back to the figures, obviously it's something that we are very conscious of in Dundee and trying collectively to do something about. And like Brian has said, some more recent local data and intelligence would be helpful. We do have, you know, an indication from our health colleagues that the interventions that we're taking on board are bringing figures down over a 5-year period. Something else we have in Dundee is called Total Place, where we have looked at a targeted approach into the whole range of deprivation, which is targeted resources which are going into one specific area within Dundee, one which has high levels of teenage pregnancy. So that's something that currently has to be evaluated, and we will take learning from that to see how that's rolled out across the city. Like Brian has said, we have a local action group which incorporates a range of partners whereby we are, looking at local intelligence and trying to move things forward. We indeed actually commissioned some local research in 2011, the reports still to be published, but it did seem to mirror national and international evidence, except perhaps in the area of social norms and this kind of generational cycle of recurring themes. So through the launch of that report, that's another area that we're going to consider to how to move things forward.
Anyone else, Molly?
I suppose could I just take up Dr. Simpson's point in relation to FNP. I think it is obviously a tried and tested programme. I think some of the limitations with it is that it's a universal programme, and my view is that all young people who come to parenthood at an early age do not have the same needs. I think some young people have very good family support and community-based support, and I think they need quite a light touch approach. Whereas I think for other young people who don't have some of those wider supports, they need a more intensive service. And I think the difficulty with a prescribed programme like the FNP is that it's a one-size-fits-all. And I think in times of resource provision where we're all trying to get the best value, I suppose, for our money, there is something for me around having services that are a bit more nuanced and can respond to actual need as opposed to treating teenage parents all the same.
Sorry, I'm not understanding that. As FNP is the very, very focused programme. I mean, in the Edinburgh pilot, there was only 180 families were actually supported by FNP, and it was from the earliest diagnosis of conception through to 2 years. So it was a very expensive, highly focused programme, which is beginning to show really quite good results. It wasn't a universal programme at all. So I don't know quite what you're referring to when you talk about a universal programme. That's just surely the general health visiting programme, isn't it?
Well, the way it's been implemented in Glasgow, it's not a targeted resource. So you don't identify your young people of greatest need. It is being open to young parents, granted a limited number at this point in time because it's in its early phases, but it's not a targeted resource at the greatest need of
Every teenage pregnancy in Glasgow is getting an FNP?
Not every, no. As I say, it's limited because there are only so many, because it's worked on a quota basis, that if you have so many nurses, they can only carry a specific caseload.
But there were specific criteria for selection for FNP. Specific criteria. I mean, this is maybe another example of a programme chair convener that they, where we start off with a focus programme which is properly evaluated, which is, very, very carefully prepared, which the FNP programme is. It's a copyrighted programme, that's supposed to follow specific criteria. If we're in a situation where this very costly programme, which is supposed to produce good results, is now being used on a much wider basis, without the selection criteria originally there, then we're going to waste an awful lot of money.
My understanding that the selection criteria is the basis of a young woman who has a pregnancy, and as long as I think she's picked up within, I think it's 16 or 20, so many weeks, then as long as that's a first pregnancy, that young person is open to attend that programme.
Tracy, you have some experience with this as well?
Yeah, well, it is my understanding that all young women under the age of 20 in their first pregnancy are open to participation within Family Nurse Partnership.
So, Mr. Kirkcaldy.
That's the point that Mariam was making in terms of it being universal, because the age criteria and the first pregnancy are the two basic criteria that would allow admission to that programme. The general point for me, I think, is that we need to become more confident in Scotland to evaluate impact of programmes that we develop here. And the limitation of something like FNP, and the reason it's so expensive, is because you have to maintain fidelity to that model in order to get the outcomes that is demonstrated, which is fair enough. If you want an outcome-focused, evidence-based approach, fair enough. But we need similar programmes that are targeted on the higher risk groups and the more predicted risk groups in our social context. And we need to be able to demonstrate the outcomes that come with that work and become more confident at spreading that across our community.
Okay. I'll let Mr Neil in, but you want to follow up on that?
Just a question on that, yeah.
It's just really to say that the Family Nurse Partnership will make an impact on the lives and the life chances of infants that are born to teenage parents. And that very much fits in with the work of the Early Years Collaborative and the Early Years Strategy and so on. And in time will lead to hopefully a generational change in the outcomes for these young people. But the Family Nurse Partnership isn't and won't do anything about the rate of teenage pregnancy. It will deal with teenage pregnancies as they arrive and secure better outcomes for the children that are born therein. But it's not about what we've been discussing thus far this morning, which is preventing teenage pregnancy.
Bob?
I think that's partially, Convener, the point I was wanting to make. I think Family Nurse Partnerships are very much about positive health and social outcomes for the families, for young women teenage women who have a child. So I think we could be comparing apples with oranges by looking at the Family Nurse Partnership in this case. But just in terms of it, would by targeting teenage mothers by definition have a weighting towards mothers from more deprived areas and more at risk? Do the statistics show that? I'd be keen to know that. Plus, second thing, at the time I remember there was discussion about if we, and I'm not personally wed to one model over another, but if we target it, then could it stigmatise some young women who'd wonder why they're given this additional support in relation to bringing up children? So I'm keen to know people's views on that. By definition, are young mothers more likely to be from socially disadvantaged areas? Do the statistics show that in the first place? In which case it would be targeted to a degree, but just more about, if it wasn't universal from within that targeted group, could it stigmatise the programme? And I'm open-minded to views on that, but I'm just given the fact that Dr Simpson's mentioned that point, it would be good to know people's opinions on that.
Yeah, there's no doubting the evidence that teenage pregnancy occurs in more deprived communities. But within that, certainly of the young parents that we work with in Glasgow, they have different needs and they have different abilities and different support mechanisms. So some young parents, or certainly some young women, will be able to maintain their own school place. They will have good family support and they manage to maintain links with their peers. So they get a very light touch approach from us. They get an involvement and both from a parenting point of view and ensuring that their education, that they remain engaged with that, and in terms of peer support. But it's a different level of support to perhaps those young parents who need something more. So that's what I'm saying in terms of that support needs to be nuanced, even within accepting that teenage pregnancy is closely allied to deprivation. And I think the way that we've tried to approach, particularly on the issue of what's the word you use there, stigmatising services, is that if you have a universal service and you call it a young parent support, then within that you can target and deliver different levels of support, and nobody necessarily needs to know the different packages. You just know that you're supporting all young parents as a whole.
Interesting. Any other comments, Kath?
I just wanted to say that I think it is targeted by the nature of the target group it's looking at. And we know that through the number of terminations in more affluent groups compared with lower socio-economic groups. And I think the other thing that's really important is the fidelity that Mr Kirkcaldy referred to, that I think if you've got an evidence-based programme, you have to have fidelity to that programme to get the results, because there'd be no point in using evidence-based programmes if we're just going to adapt them. So.
Richard, do you want to come back?
Oh, no, that's okay. Very helpful to explain that. It's very useful.
Yes, please.
I just wanted to add one other thing relating to what Dr Simpson said, and it was in terms of do people in deprived areas maybe need a bit more, and I think that may be the case, and we would certainly be targeting our deprived areas, but I wouldn't want the rural aspect to be missed, because actually delivering services in a wide geographical area, it would be wrong of me to come from Highland and not make that point, that the cost of rural service provision is significant and it is much more difficult. And for example, we use Brook on a Saturday afternoon in Inverness. Now, that's miles away from some people in Highland, but we do know that lots of young people do go to Inverness, so at some point during the week, at some point, they might be able to access something, because they can go to GPs, they could go to a community pharmacy if there is one, but it may well be your mum's friend who's the receptionist or whatever in these communities, so we need to bear that in mind as well.
Okay. Is there any other questions for the panel? Aileen.
Thanks very much, Convener. I'm just conscious this morning that one area that we haven't really touched upon has been in terms of looked after children, and sort of our young people in care, and also those who are leaving care as well. And certainly from the written evidence that we received from the Centre for Excellence for Looked After Children in Scotland and Who Cares Scotland, and they sort of said that the young people with care experience the recognition that they tend to be at a higher risk for having a child at a young age, and some of that may be down to them wanting to be loved and also to actually have someone to love. So it was really just to kind of ask the panel this morning, that the other issues there are around that these children are perhaps also disengaged from school, and they're also maybe excluded from school, and they're more likely to experience disrupted education. And also for myself, representing a very large rural area like the south of Scotland, and in particular Dumfries and Galloway, where we're trying to ensure that in a rural area like that, we're trying to access the appropriate services, but there is the added challenge in terms of looked after children as well.
No response? Yes, please. Yes.
I suppose in Glasgow, the main way that we've tried to tackle that is through skilling up the workforce who work with looked after and accommodated children. So we have done significant training with residential workers, with Families for Children staff, and the parenting programme that I talked about, Talk To, has also been adapted for foster carers. So again, it's very much that idea of talking with the young people and talking early in a way that's appropriate to their age and stage development. And then the other issue then is in terms of having specific looked after and accommodated health teams that can again provide services in a very holistic way to young people, but that includes sexual health as part of that. So it's been very much a trying to, as I say, skill up the individuals around young people so that they feel confident and are able to talk with young people about the various issues involved in their lives.
Just echo what Marion said, very similar approaches within my local authority. Again, I spoke earlier about the Speakeasy programme. We have been upskilling our workforce, foster carers, residential workers within the city. We've also had the introduction of specific school health nurses, but they're specifically aligned to looked after and accommodated young people. And engagement through the voluntary sector to provide interventions with regard to sexual health and relationships.
Yes, Mr. Allen.
Just to say that at school level, a frequent feature is the school liaison group of community partners who meet on a regular basis within our school and with all schools in Fife, all secondary schools, in fact all primary clusters now also. And the needs of looked after children are always part of that particular agenda. And the named looked after children are discussed in terms of the GIRFEC framework and the Shinari indicators, the safe, healthy, etc. And health needs at that particular point may well be part of input to the children's plan, which all looked after children will have.
Yes, Mr. Naylor.
Similar approaches where looked after children have key workers assigned, the inputs that are made not just in relation to sexual health education, but to do with a whole lot of range of outcomes for looked after and accommodated children are targeted and supported. I think the point I would make, just picking up on what Ms MacLeod said, outcomes for looked after and accommodated children are pretty bad generally across the piece, both in terms of educational attainment and in terms of health outcomes. And certainly one of the things that we're working on is to try and change the culture within all of our schools in terms of the inclusion agenda. It was mentioned that oftentimes, far too often, looked after and accommodated children end up being excluded from school. And we're working currently to try and develop a culture where there's a presumption that you would not exclude a looked after or accommodated child because the best place for them to be is in school, and the best that we can do is to very, very quickly organise our extended support teams and our multi-agency frameworks around children whose behaviours are leading them to be excluded from school, and to try and get things in place and appropriate supports immediately that they don't end up back out in the community where they're likely to be most vulnerable, not least to getting involved in behaviours that could lead to pregnancy.
Anyone else? No, thank you. Is there any other questions for the panellists? No, we as a committee have had a number of visits, and we have seen some very good projects that support young mothers that we visited in Glasgow. But on the figures here, there's a significant number of abortions for under 20s. So how do we see young people through that process? What sort of supports in place for them? Do you know about these young women or not? Or is there any? Are they picked up in the system? Are they supported? Yes, Marianne.
Well, the majority of young people, young women seeking a termination are dealt with through the health service and through, in Glasgow, it's specifically Sandyford services, and would have a key role to play within that, as well as through GPs and other services. I think from a kind of council point of view, that is sometimes issues are picked up within schools by pastoral care teachers and would be dealt with sensitively. And there is also a link midwife for teenage pregnancy within Glasgow, who again would be getting early indications of pregnancy and would be talking with that young person about how they wish to proceed. And occasionally the young parent support base as well, by the time they get notified of a young person's pregnancy, a young woman's pregnancy, she still may be having doubts as to whether she wishes to proceed. So there would be certainly discussion and counselling involved through that.
Anyone else? I'm just thinking about the confidentiality, and I think we discussed it, that, about the exchange of information, what information can be exchanged, so that they can be supported in this. Is that a similar experience? Is that how we would handle it in Dundee, Highlands, or anywhere else?
Yes, it's similar. It's a confidential matter at individual level, and it would be specialised services around the young person who would support them and their family in that context. Schools would not be directly engaged in that usually.
Okay. The other aspect, which is we sort of goes over, is the influence of alcohol and drugs to this. Does anyone wish to put anything on the record in regards to the significance of alcohol and drugs in regards to unplanned teenage pregnancies? Luke.
I mean, they kind of all go together.
Yeah.
It's a list of kind of risk-taking behaviours, and we know that many young people's early sexual experiences, alcohol is often involved, more than substances, I would suggest, but alcohol is often involved. And I suppose some of that is about young people's behaviour in general, but if you actually look at young people's behaviour, it's not that much different to adult behaviour. And I think there is something, there's a kind of cultural issue, generally speaking, in terms of how we deal with sex and sexuality. That's where there is that association of people needing that Dutch courage or using alcohol to excuse behaviours.
Anyone else? Mr. Naylor?
We certainly have instances within Renfrewshire where our home link workers are working with young women who have self-esteem issues and who may be involved at weekends in offering sexual favours in return for drugs or for alcohol. And therein you have a cycle where you're really needing to work with young people on their self-esteem, their sense of self-worth, as well as steering them away from alcohol and drugs. But I would agree with what's been said, that these things often go together, particularly where drink is involved. Often young women are getting themselves into situations because of drink and because of desires to belong and fit into a peer group that is leading them into these kind of behaviours. And that's partly driven by modern media and the depiction of women and how they ought to behave and so on. So I think there's a much broader cultural issue there, but it is fuelled and driven to some degree by alcohol and drugs.
Tracy, did you want to?
I just wanted to say that absolutely the agendas are all connected, and we need to get better at looking holistically around risk-taking behaviours. And certainly some of the interventions that we're working on, it's not about putting them into a silo of just sexual health or teenage pregnancy. It's a much bigger picture, and it's everyone's responsibility to address this issue.
Nanette wanted in, I think. Nanette?
It's just something that occurred to me, talking about the vulnerability of people due to drink and alcohol. I mean, certainly in Aberdeen, and I think in Inverness and one or two other cities, there's quite an active group now of street pastors who are speaking to young people who might become vulnerable at Fridays, Saturdays or whatever. I was wondering if there's any role, any training for these sort of people in just the issues we're discussing today, just in advising them on sexual behaviour. And I know they don't want to sort of preach at young people, but I think I wonder if there is a potential role within that, or if there already is. I don't know.
I suppose there are connections, and I mean, it's back to those connections I was referring to earlier. If a young person is admitted to hospital because they have taken a dangerous amount of alcohol, how does that feed back into the system? If someone's stopped in the street, their name's taken by the police and alcohol is confiscated, how does that feed back into your system? If we're actually targeting that risk behaviour, how does that become a more positive experience? Mr. Allen?
Fife operates a programme called MATE, M-A-I-T, the Mobile Alcohol Intervention Team, that involves social work, youth work and police officers. And there's now a link back to schools from that particular reporting mechanism, so we can get involved in that as well and follow up any alcohol confiscations. They have a team that concentrate on hotspots and tour certain areas within Kirkcaldy on certain evenings. So it's a way of tying it up and involving the youth workers in counselling on sexual health and other matters, as well as other risk-taking behaviour generally.
Right. Mr. Kirkcaldy?
Just to echo that, we have a multi-agency approach to all of this. So we see the risk at the top end of the risk pyramid to do with alcohol and substance misuse as part of a bigger challenge. So any information that comes to the police or to the NHS would be shared with other members of the partnership, including the education service and community services, to see what part we can all play. That would happen at Fife level, it would happen at area level, and it happens at school level as well.
Mark?
Yeah, it was just off of the back of Nanette Milne's remarks. Having been out with the street pastors in Aberdeen, I think their focus tends to be more on those who are out in the nightclubs and the pubs. But it brought to mind that the churches have a role as well, I think, and certainly in the community where I live and used to represent as a councillor, the local church in Dice have what's called the Red Bus Project, which unsurprisingly is a big red bus where at the weekends, in the evenings, it offers an opportunity for teenagers to get involved in maybe youth activities and things like that, diversionary activities, which takes them away from maybe some of the other risk-taking behaviours that they might otherwise get involved in. And I'm sure there will be other examples that members could cite from within their local areas as well. So I think that the role that the churches are playing is also something that bears, consideration as part of the inquiry.
If there's no other questions, it's at this point that I offer our panellists an opportunity to put on record some of the issues they feel that they wanted to cover, which never come out in the session. Some observations or indeed ideas for the committee in terms of, as we proceed with this inquiry, what do we need to look at? We've had some, in terms of the information that's collated. I think we could maybe cover that again. But what that should be, is it good enough to simply list the number of pregnancies, deliveries, terminations? Do we need to examine this issue? Maybe, I don't know, looking at other health stats that could be provided that indicate a level of risk-taking behaviour or whatever. I don't know. But now is your chance, but not final chance, because obviously you can write email to the committee, and we welcome any further submissions on and comments on the evidence that we've taken and before we finally get to our report. Is there anybody wish to put anything on the record before we move to close the session? Yes, Mr. Naylor.
Just a comment, which would be that I think we've heard this morning about a great deal of multi-agency approaches, people working in partnership across the various services and so on to try and tackle this issue. But the responsibility for the lead agency in this regard has moved towards local councils to be taking a strategic lead in terms of being a provider of universal services, not least the education service. And I think in these straitened times, I would have liked to have seen some kind of consideration of resource transfer. If local councils are now in the position where they are driving forward this agenda, albeit with their partners, we've moved away from the idea that this is simply a health issue to a social and demographic issue. But there doesn't seem to have been any transfer of resources as far as I've been able to see.
Thanks for that. Is that a comment, or is there anyone else?
I suppose just to say not to see the data that you've referred to in isolation from other statistics that are available. I think we do need to see a more holistic approach and bring performance measures together and not in isolation. Okay, thanks for that. Yes, Molly.
I would echo the view there just about transferring resources. I know it may not be a popular cry in this day and age, but I think to sometimes pump prime and to start off initiatives, you do need a measure of resource at the beginning that then can become embedded in common practice. I think there's a couple of issues around, I think a lot of focus, certainly in Glasgow to date, and I think more broadly, has been on the younger group of young parents, that group of young people that are still school age. I think there needs to be a greater focus on older teenage parents, because many of the social issues that come up in terms of parenting arise once a young parent leaves home, is out in their own tenancy, and engaged in a world that they struggle to deal with at times. And I know certainly in terms of for those young parents that do become involved in child protection issues, it tends to be the older teenage parents where that is a focus. So I think there needs to be more attention there. I think I would echo Brian Kirkcody's point around needing to look at how we evaluate homegrown strategies, because I think, and I obviously only speak for Glasgow here, but I think the initiative that we've developed in Glasgow with the young parent support base is a good model. And I think it would be useful to look at how that develops, and look at how we can evaluate it to the extent of having it, classed as an evidence-based approach. So that would be another point I would make. And then finally, I think there's a discussion going on within ourselves at the Young People's Sexual Health Steering Group at the moment. I think there's a broader issue around the sexualisation agenda. And I know that Linda Papadopoulos did a report for the Scottish Government in 2010 that looked at a range of issues, that looked at the commercialisation of sex and the commercialisation of childhood, and how difficult it is for young people to operate, I suppose, in a world where there's a great deal of pressure on them, and at increasingly early ages as well. It's not uncommon now for primary school children to be talking about dieting and very conscious of appearance. So I think there's a whole cultural range of issues underneath what we've been talking about today that puts pressure on young people to engage in sexual activity at an earlier and earlier age. And I'd like to see some emphasis on that.
Yeah. Well, thanks for that. I mean, we could have another session about those 3 points, and we understand that, it is a difficult area. Mr. Kirkconnell.
Just to echo that point about the evidence-based approach, we think we're in a phase, we're very actively working on innovations. We think we're developing a lot of progressive initiatives that will have impact. If we can demonstrate the evidence that's associated with these innovations, then that puts us into a different position in terms of the social and political context in which schools and local authorities have to operate. If community planning partnerships and local authorities are going to have a lead role in this area, and we want to develop further our approaches, we need to be able to agree these with our communities. And this is a controversial area. If you develop innovations in the field of sex and relationships with young people, you create a backlash potentially politically and in the community, as people know. And so the more evidence that we can cite in terms of impact of innovations, the better, if they work.
Well, really just building on that, one of the things that we don't want is just projects, short-term things that aren't picked up at the end of them. And I think taking an assets-based approach in communities is probably the best way forward, and looking at what's already there and what can be built on would be the most cost-effective way of doing it and keeping communities on board.
Okay.
I would echo that. Some of the biggest innovations within Dundee in the recent year have been through an asset-based approach and looking at what we already have in the community. And indeed, some social enterprises have been established through that, a lot of peer support groups and innovative practice. And it is around evaluation of that and having that as a strong evidence base for moving forward.
Is there anyone else? No. Thanks for that. It may be, if you mentioned the 18-year-olds, because our focus has been, just again on the figures. And the figures show that we've got a problem with 16-year-olds, and it's very interesting just to put that in. So if there is anything available there with Spice or yourself that you could prompt the committee, because you know, we're talking about where we've got access to young people through schools and whatever. At 18 we haven't, and although the figures went down, it doesn't mean to say that the problem is less challenging. Indeed, you point out very briefly, it may be more challenging. So, you know, I think that would be useful for the committee to have if you've got any additional views or some figures on that. And you know, for everybody to take that on board. Thank you very, very much indeed for all of the time you've given us this morning and the evidence we've taken. We'd encourage you to continue your participation by looking at the other evidence sessions. If there are issues that are raised that you strongly disagree with or even agree with, then please let us know. We would value your continued input until we draw up our final report. But thank you all very much for your attendance here this morning. We appreciate it. Thank you. Suspend at this point until we set up the next panel. Thank you. Agenda item number 2 continued, and we welcome our new witnesses with us. Sally Egan, Women and Children's Health Commissioner, NHS Lothian, very welcome. And Carolyn Wilson, Operational Policy Manager, Child and Maternal Health Division of the Scottish Government. Welcome you both here to our evidence session this morning. We're going to go quickly to questions, and we can have a discussion, hopefully. Bob Doris.
Thank you very much, Convener. And we had quite an interesting discussion at our earlier round table this morning, and some of those themes may come up again, whether it's about work going on within schools to raise self-esteem and empower young females to make positive choices, not to have pregnancies unplanned or otherwise. And we heard a variety of measures, including family nurse partnerships in terms of supporting young mothers when they do have children. But we also heard about the possibility of a gap in provision where the most socially excluded young people who may be most at risk of having an unplanned pregnancy may be less likely to engage with even with the high quality school services. And what work has been promoted in the community out with traditional education routes to support young people most at risk of unplanned pregnancies? I think that would be a useful starting point.
Well, having listened to the earlier debate, I think it's not one thing. I mean, it's a whole joined-up approach, and it's very much cyclic and intergenerational. So how we tackle this isn't just through a sexual health strategy, and that's something that within NHS Lothian and the 4 local authority and wider partnerships that we've encompassed. So it's very much about what is it that we need to support children into education, what is it we need to prevent unwanted pregnancies and early pregnancy, what is it we want to support parents. So it's a whole holistic approach to joining up all these different strategies. And I think for me the very sort of challenging thing that we've learned out of FNP is, we've heard people saying, well, family nurse partnership comes in after the child's born, but in that early stage when we're trying to engage some of these young people, it is a challenge. It takes a lot of work from the family nurses to get them to accept their eligibility into the programme, because it's not compulsory and we have a very good uptake rate. But when you actually look at some of these girls, and with us being the first pilot site in Lothian, it gave you a chance to look at case studies and why did it get to a stage where there was an unplanned or maybe a planned pregnancy before there was any real intervention for some of these kids. Not for all of them, because some of the children were, as we heard earlier, probably they could have went it alone with their family, but that's making a discussion about the resilience. But for other children, it really was concerning to think that they'd reached that stage in their life, 14, 15, 16-year-old, before there was any real positive intervention with them that was recognisable. And I think that's changing, and it's changed over the years, and I think we'll see big changes in the future. So for me, our early years collaborative to encompass the whole maternity phase, so that if a young person does get pregnant, we know about it early on, and we can tackle it, we can help them, assist them, involve other agencies, including the voluntary sector, to make an informed choice about whether they continue with that pregnancy. If they're not going to continue with the pregnancy, how do we support them? In Edinburgh, we have family nurse partnership. We don't have that across all of Lothian, but we do have other programmes. Thinking back to the whole early intervention, if we identify children's needs at the earliest opportunity, we can work with those children to improve their self-esteem. We can work with teachers, we can work with parents, so that we're actually promoting a resilience in children at the earliest opportunity. I think within the local authorities that I work with, they've certainly moved away as far as possible of exclusion. That will be a last resort, and they will try to work with children to stop them becoming excluded, either in school or excluded, an actual formal exclusion out of school. So it's difficult to put into words, but I just want to make the point that there's lots going on, and I don't think we'll see the real benefit of that probably for another 10 years, because it will take that length of time to really evidence. We'll see some differences and some reductions, but I think to see a real turnaround in this, it's going to take a sort of multi-agency, multi-intervention, early intervention approach.
Okay, Ms Wilson.
Yeah, could I just in terms of clarifying what I do, I'm the policy lead for the Family Nurse Partnership Programme within the Child and Maternal Health Division. Our division has a focus on supporting women when they enter maternity services and obviously child health and development. So we don't, within our area of government, have a focus on the sexual health elements or preventing teenage pregnancy. It's more supporting teenage parents or all parents when they become pregnant and helping them access the services that are available to them. So really just to sort of clarify the point about what I could add in terms of your question. I mean, one of the areas that we've worked very hard on and done a lot of work on recently is about access to antenatal services. And we know that particularly teenage parents are one of the most vulnerable groups in terms of not being able to access those services or least likely to access them. So there's been a number of measures put in place. The refreshed the refreshed maternity services framework, which has sort of brought that to the fore to allow health boards to create an environment where these services are more accessible and to encourage people across all the deprivation quintiles to access the services on an equal basis.
Okay, well, can I ask specifically on family nurse partnerships, given that you're leading on that, Ms Wilson, one of the issues around teenage pregnancies can be that if the proper support's not put in place, then one child becomes two childs and you have kind of larger families. Would there be monitoring, or would we expect one of the outcomes of family nurse partnerships to be that those people you're working with will be far less likely to have a second or third child in the years ahead? And I appreciate that takes some tracking over a number of years, but is that one of the outcomes you'd be keen to see an evidence base for?
Yeah.
If you could maybe say a little bit more about that, and of course going far longer term, depending on how long we are wed to this particular model. Young mums that are going through family nurse partnerships at the moment, their kids, when they are 13, 14, 15 years old, traditionally have been at higher risk of then being teenage mums themselves. Should we expect to see, and politicians are always accused of going for the short-term gains, so I'm talking the long-term, in 10 to 15 years' time, when I suspect most of us around this table will not be sitting here, should we expect to see, Mark MacDonald says he certainly won't be here, through choice, I'm sure, should we expect to see a dramatic turnaround? And it seems glacial in political terms, but actually in social terms, a fairly short period of time, 10 to 15 years. What would your hopes be for the statistics over that time period?
Yep. I mean, certainly the evidence base for the family nurse partnership is that through the randomised controlled trials in America, is one of the outcomes we would expect to see is wider spacing of subsequent pregnancies and a longer period and more planning between the first and the second births. So we certainly would expect there to be more thought given by the young mothers in terms of their goals and aspirations, and having a number of children very quickly at a very young age, how that could impact on their ability to meet those aspirations. So we have done an evaluation of the Family Nurse Partnership Programme in Lothian to allow us to understand how the model could be implemented in Scotland and whether it can be implemented in Scotland, and that has been very positive. One of the pieces of data that we've gathered for the most recent report is around subsequent pregnancies and subsequent births. So there has been some of those, but not of a number that we would have expected at this stage. But I think as we go on with Family Nurse Partnership, we would expect the evidence base, because we're implementing the model with fidelity, to show those outcomes to sort of appear, you know, and to be maintained. So we would expect wider spacing of pregnancies, better planning of pregnancies, and a longer period between the first and second birth as we roll out the programme across Scotland. The evidence in terms of the children of mothers who have gone through the Family Nurse Partnership programme in America is there is evidence on the behaviours of those children, and what it does show is that their behaviours are different from those of their parents. So they are less likely to become teenage mothers, they are less likely to be involved in violence, alcohol-related crime, domestic violence, all these sorts of things. And it has got a very strong evidence base now for breaking that intergenerational cycle of poor outcomes and poor behaviours.
Okay, can I just ask very briefly, Convener, and obviously you can only make projections in the medium to long term based on evidence from the USA with the Family Nurse Partnership in terms of second and third births for teenage mothers, but we probably can get data quite quickly in terms of the spacing or frequency of that from Scotland. What would be a fair time for this committee or the government or whoever's analysing this scheme to say, well, actually, that's 3 years that's been running now, or you tell me how many years you think, and we can actually get some data that's meaningful in terms of, well, you know, with randomised controlled trials, we can find out the spacing between first and second pregnancies have increased. There's less second pregnancies. What would be a fair time to start to look at that data and find out if it has the same effect as it's had in the States?
Well, certainly there's a randomised controlled trial going on in England, and we are using the evidence from the trial in England to inform the implementation in Scotland. So we're not actually going to carry out a randomised controlled trial in Scotland, not least because there's not enough clients come through that we would be able to do that effectively. So we would expect to see some evidence from the English randomised controlled trial around pregnancy spacing, probably within the next 2 to 3 years. They have got very high numbers of people on the programme. We have got still very small, relatively small numbers. So actually to draw out trends and to look at outcomes just based on very small numbers, I think, you know, might not be the best thing to do. I think we probably have to wait again in Scotland at least maybe 2 to 3 years before we could start looking to see whether those specific outcomes were actually being shown to be the same in Scotland as they are in America. But the fact that we're implementing the same programme, the fidelity of the model is being maintained across all the sites in Scotland, everybody is implementing the programme in the same way. The support is tailored to meet the needs of the individual client and to address any issues they have at any point in time. But the core programme is the same for each client. So we wouldn't expect the outcomes to be any different than they were in the research trials in America.
And one final question, Convener, if that's okay. It's obviously you can't compel people to take part in the Family Nurse Partnership. If someone decides not to take part on it, there could be a variety of reasons for that, of course, but one of them could be their vulnerability and lack of willingness to engage. Is there any follow-up work or other alternative support services that are put in place at that point?
Yeah. If I just say a wee bit about the engagement, and then I'll maybe let Sally talk about the follow-up services. In terms of eligibility for the Family Nurse Partnership programme, the criteria is very broad. It's 19 and under, no previous live birth, and living within the geographical reach of the programme. That means that we can offer the programme on a universal basis to all eligible women within a given area. What we do know is that at least 75% of teenage mothers are within the first 2 quintiles, deprivation quintiles. So we know that we are reaching the most vulnerable, or have the potential to reach the most vulnerable. What we also know from evidence from Lothian and from Tayside and from the new areas that are taking the programme is that we have at least a 75% uptake. So those that are offered the programme, we have at least a 75% uptake, if not higher. Certainly in Lothian it's nearly 80%. So we know we are reaching all the women who are in need of additional support. We also know that some of the women who come onto the programme are in some way self-selecting. Those who are in most need, who appear most vulnerable on paper, are those who are most likely to engage in the programme, and actually are those who benefit most from the programme. The ones who are less likely to engage in the programme potentially have a wider support network available, come from more affluent families, although they themselves don't have a high level of income, as do very few teenage parents. So the majority of them do live, within a very sort of deprived income base. But the ones who do not engage with the programme or who do not stay engaged in the programme, we do have very good links with the universal services, the maternity services and the health visiting services locally to ensure those clients are transitioned back into universal services and are continued to be supported in a effective way that meets their needs. And I'm sure Sally can give more information on that.
Yeah, I mean, in Lothian, we've been very lucky in the first cohort, and it will continue with the second cohort that we've just entered into, in that the family nurses, they can actually identify these young women at the very earliest opportunity. They're not dependent on referral from a midwife, but we work very closely with the midwives throughout the whole pregnancy phase. We have an electronic system, which is the electronic e-swimmer, it's called, which incorporates the Getting It Right for Every Child. So at booking, every mother who books, and we try to get 80% minimum, that's the heat target, booked before the 12th week, we actually have no problem getting the majority of people booked because they want to get their scan. So it's not a hard heat target, although we do need to concentrate. If we're not getting people, why are we not getting them? So the family nurses are able to identify sometimes as early as 10 weeks, and sometimes there could even be a subsequent pregnancy loss. But again, they handle that very sensitively. So up until about, hopefully they've got most of them engaged and sign up by about 14, 15 weeks, but anything up to about 16. But that is that real intensive period, which makes us ask, how do we manage to do that if someone isn't pregnant? If they're having behavioural problems at school, or if there's other issues within the family, how do you actually get a young person to engage with a professional across any discipline? Because it's a very intensive period. But the midwife is also involved. It's midwifery-led care at that period in time. So if the young person doesn't want to sign up to the programme, they're eligible for it, we sell it as this is a good thing for you, it's a good thing for your baby. We know that most children and young people want the best for themselves and their babies. So it's not that hard to sell once you get them engaged, but that's the hard bit. So it takes quite a lot. You could give up. In my previous professional life, it'd be so easy to give up after 2 or 3 contacts if somebody didn't want to engage with the service. So I think there's something that we need to learn in general about that engagement period. But during the whole pregnancy phase, we work very closely with the midwives. If the mum to be wanted to leave the programme for any reason, the midwife would still be involved. If there were other cause for concern issues or child protection issues, there would be a wider network of people involved. But again, in relation to all those services, we are identifying the person at an earlier stage. So what my own experience, having worked with this programme, is that the other agencies get involved much earlier as well, so that you're building up that resilience both for the individual and for their wider family at a very early stage. So we do have attrition, but it's small and it's far and few between. If it's after the baby's born, of course you've got the health visitor, and if we think there's a risk that they're going to leave, we will try and introduce them to the health visitor, and the health visitor would take on the role. And some people do prefer that, but as I say, the evidence is the attrition rates are quite low actually. Usually if people leave the programme, it's for a very good reason. They're either very self-sufficient and resilient, or they're moving to another area. It's generally not just because they fall out with the service.
Okay, thank you.
Richard?
I just wonder about the percentage that's presenting late, because they're often the most vulnerable. I mean, they sometimes don't even know they're pregnant. Is there a cut-off point which they have to present by before you can take them into the programme? Because that was one of the criteria that quite concerned me about it, as they are amongst the most vulnerable. So
Trying to get them by 16 weeks, but
yeah.
you know, after sort of 26 to 28 weeks, because in terms of the programme and what it's trying to deliver, you have to start early on in the pregnancy
yes.
to actually deliver across the various domains.
With fidelity.
Yeah.
Yes.
Now, in the first cohort, because we were, you know, recruiting very quickly into the programme to get the numbers up, there were some later, you know, girls of a later gestation recruited into the programme, but we did have to say to a couple of parents, it was less the kids themselves, but their parents were arguing why could they not get into the programme. We had to be quite strict about that, because you must deliver it as per the licence, because you wouldn't get the results if you brought them in at that stage. But that wasn't to say that we would ignore those kids. We would make sure that they had some other intensive support during that pregnancy phase.
So that's the bit I'd like to explore a little bit more in terms of policy. Given that we're trying to, I mean, quite rightly, do a programme that does have fidelity, so that we can see the results. What is your policy now, generally, at a Scottish-wide level, to deal with those who are not going to be eligible for the programme, but are undoubtedly amongst the most vulnerable in that risk group?
Yeah. I mean, I think it's a very valid point, and obviously they are a very highly vulnerable group, and young mothers are more likely to have concealed pregnancies and present late to services. One of the things I would say, and just to make the point that we've always had pregnant teenagers, and there always has to have been a level of support. I think what we've learned through introducing the Family Nurse Partnership Programme is that actually there wasn't any specific tailored support available for these young women, and the focus was more on they were just treated as part of, you know, the wider services that were available to all pregnant women. We've learned a lot, and we have shared a lot with services, and I know, I'm sure Sally would endorse this, that it certainly in Lothian and in Tayside, we have a better understanding now of how to engage particularly young mothers in universal services, how to get services to tailor their support to meet these individuals' needs, but also to get them to understand what the needs of the individuals are, and how to access them in a more flexible way rather than just through the standard channels. So one of the things that we would hope from the Family Nurse Partnership is that there would be less late presenters and concealed pregnancies, because the services are now waking up to the fact they need to work together to identify these young women and to support them very early on. But the point that you made around maintaining the fidelity of the licences, the criteria is up to 28 weeks gestation. So we wouldn't be changing that because that is not part of our, we don't have the ability to change that as part of the licence. That is where the evidence is strongest, that you need to engage them by that point for them to benefit from the pregnancy part of the programme.
Can I ask a separate question? One of the areas that was touched on this morning in the first session was problems with drugs and alcohol. And I know that Lothian does have a specific team dealing with people in that area once they're pregnant. But I just wonder whether these services are connected up. When I was working in Glasgow in the Gorbals, we actually had a sexual health nurse attached. Mary Hepburn was kind enough to allow a sexual health nurse to be attached, and we were able to actually reduce the level of teenage pregnancies amongst this particular population who are very severely at risk. First of all, what's happening in Lothian, but also at a national level, what's the policy on making sure that there is effective sexual health input to all the drug and alcohol teams.
Speak from Lothian. Well, the service that you refer to, it's an Edinburgh service, it's called Prepare, but we also have a young teenage pregnancy support service in West Lothian as well. And the people who sort of design the strategy and the implementation plans are all very much interconnected through various Lothian and community planning networks. But the Prepare team is a dedicated service that is for severe substance using mothers, and we have a dedicated midwife and health visitor attached to that team, as well as social workers, nursery nurses. And very often the women who access that service or who are signposted to that service or that we pick up and encourage into that service are much further on in their pregnancy, and they tend to be older. Some of these women are women who have had pregnancies before, they may have other children in care, and they are very highly complex individuals. We tend to see less of that complexity within the age group that we're talking about within Family Nurse Partnership. But the same strategic planning teams are involved, the operational managers, cut across the two services, and there is healthy dialogue. In terms of contraception, we spoke about time interval for pregnancy. We have the nurses within both FNP and Prepare are very highly trained in contraception. If they are not trained to deliver it themselves, then they will get the young person or the person from Prepare up to our sexual health clinic so that they can get some of the very long-acting reversible contraception inputs at the earliest opportunity. So the services are very much joined up. And as I said, we try to not say you've got a sexual health strategy here and you've got an early years strategy here and a substance and alcohol use. I happen to work very closely with all the strategic leads in health that cut across these particular programmes, and we do have a joined up group to make sure that we are taking things forward in a cohesive and planned way. And I think the work with the Early Years Collaborative is beginning to prove how important it is for all of these services to work together.
Yeah, and certainly at a national level, as I said before, there's the Refreshed Maternity Services Framework, which one of the aims of that was to encourage particularly midwives to look more broadly at some of the social factors relating to poor pregnancy outcomes, and linking in with other services to create a sort of holistic approach to supporting these women. There is another piece of work that's ongoing that's sort of fell out of that, of the Maternity Care Collaborative, which is linked in to the Early Years Collaborative. So there's a lot of work ongoing. There may be other wider policies specific around alcohol and drugs, but they're not ones that I'm familiar with at this point.
Also within our inpatient service in maternity up at Simpsons, we've just introduced for our most vulnerable mothers who have delivered the opportunity for them to have long-acting reversible contraception before they leave hospital, and that's just a very recent innovation within Lothian.
I think that last point is quite important. The LARC is, allowing that to be much more widespread is important. At the other end, there's community pharmacy, and their evidence to us, written evidence, talked about the longer-acting emergency contraception, which is approved by SMC but is not generally available yet. Is there anything on that? Any comment you'd like to make on that? It works for 72 hours rather than 24 or 36 hours for the traditional levonorgestrel approach. So is it called Ulispretrol or something? I can't remember the name.
I can't give you all the details of that, but I can certainly get that we are planning to introduce that in Lothian. There are discussions going on with GPs and pharmacists at the moment.
Thank you.
Okay. Mark MacDonald.
Thank you, Convener. Earlier in today's session, I asked some questions around role of family, role of fathers. Obviously, these young females do not get pregnant by themselves, and I wondered what work was being done where possible and where appropriate to involve the father in the process. Obviously, there will be circumstances where that is not appropriate, where, for example, the pregnancy arises as a result of an abusive relationship or as a result of a relationship that is built around things like drugs and alcohol. But there's another factor in that as well, and something which was picked up during the visit that Nanette Milne and I undertook in Dundee, and that is that often there is a willingness of the father to be involved in the upbringing of the child, but the family of the mother resists any involvement because of the stigma that is attached around a teenage pregnancy. So what work is done firstly to try and encourage fathers in these situations to be involved, because obviously that will be beneficial to the child that is the product of the pregnancy, but also to encourage the family of the mother to accept the involvement of the father and to allow them to have an involvement in the upbringing of the child.
Well, certainly, in terms of the Family Nurse Partnership Programme, the programme is delivered to the mother, but there's every effort made to involve the father in those sessions and to involve the father more generally. And that can be both the biological father and or the mother's new partner if they're no longer living with the biological father. One of the key aspects about the Family Nurse Partnership is about relationships and allowing the young mother to explore and understand both the relationships with with the biological father and or their new partner, but also their relationships with their parents and their peers. So one of the focus of the programme is to allow them to explore those issues with their family, for them to bring the father, whichever father figure, whichever it may be, into the programme and into the child's life, and to let them make decisions on when the engagement can happen if the father doesn't live with the mother. I certainly think more generally there's a lot of evidence that, particularly in maternity services and even in health visiting in the early days after birth, that the father is not involved in those visits and is almost in some occasions actively excluded from any discussions on the child's well-being or indeed the pregnancy as it's progressing. So one of the sort of key things that's been brought through, as say from the Refreshed Maternity Services framework and from some work that is ongoing at the moment, is to involve the father more in these aspects of the child's journey and to make them feel more involved, because we know they want to be involved. We know they want to be part of their child's life. We know they want to understand what they need to do to help shape that child's outcomes. But what they lack is either being given information or being supported to understand that information that they're being given.
I mean, I think from a general perspective, the midwives, as early as possible, will try to involve the fathers, but very often dads, if they're fortunate, they are in employment, so at the time that their partner or their wife may be attending clinics, they might not be available. But as the pregnancy progresses and we get into the sort of later stages of pregnancy, very much try to involve both partners in terms of what to expect, letting them see the videos of the birthing suite, the unit, trying to do home visits maybe that will suit, that maybe the dad will be there to encourage it. And again, the health visiting service, but the way we design our universal services aren't always that conducive. We do try to take the views of the father into account, and our parenting programmes increasingly for those children where it's deemed that a more a targeted parenting programme is appropriate, we definitely involve the fathers in those programmes. I think the Sure Start schemes, there's various different sort of models around Sure Start, again involve fathers. We've got other voluntary sector projects that work both in the pregnancy phase and in the early years, toddler phase, in and around Lothian, projects like Stepping Stones, where again they would take into account the partner, the male partner, or the father's views. I think the other thing to mention here is that the midwives, when they're actually doing their assessment, their early booking antenatal assessment, getting the women booked up for the services, they do a number of maternal risk questionnaires, and one of those questionnaires in Lothian is around routine inquiry for gender-based violence. So again, you know, it's important to recognise that in some relationships you may not want you may want to actually start to intervene early. Is it appropriate for that father to be involved? And sometimes, you know, we have to encourage women to make disclosure and to actually work with them to get a plan that's safe for all of them, including the father, but get the father the help that he needs at an early stage as well, because he may want to be very much involved, but there may be risk factors there as well.
Okay, thank you.
You know, in your pilot and as it's been rolled out, what sort of results did you get with increasing a positive role for the father? Or is it one of your objectives? Is it somebody else's objective?
It's certainly our objective in terms of fathers' engagement. We do collect a lot of data in relation to the implementation and delivery of the Family Nurse Partnership Programme, and that is used both locally in terms of delivering the service, but also nationally in terms of shaping our understanding of what the outcomes are. And we do gather data on fathers' involvement, and we've got both photographic evidence that fathers are actively involved in the caregiving of their children, but also a lot of evidence that for the majority of sessions between the nurse and the client, the father or significant other is present.
So there's information you can share with us, rather than photographs?
There's information in the current evaluations around that. I mean, what the programme doesn't do currently is collect a lot of data on the father, so in terms of their history, their background, any previous children they may have had. That might come up in conversation, and it may be anecdotally put into the evidence and the evaluation if the client discloses that, but we don't specifically gather detailed demographic information and characteristics on the father. If
it's one of the objectives, I presume that's a desirable objective.
Yeah.
It's something that is important.
Yes.
So why wouldn't you do all of...
Well, I think it's important to understand if the father is present and engaging with the Family Nurse Partnership Programme, is using the skills and the information and support that's provided by the nurse to then, you know, use that in the caregiving of their child. And there's certainly evidence of that. So I'm not quite sure what else it is that you...
Yeah, I'm just searching for, you know, some idea about whether this is working for the objectives. That's what I'm saying. Okay. Why that would be your objective when you're not collecting, you know, there is some evidence, there isn't some evidence, rather than somebody else doing that job who could do that job better than the Family Nurse Partnership. I mean, what I'm trying to get here is that I've listened to some of the objectives that we're investing a lot of money on, that's been rolled out across the country, and that the most difficult people in terms of chaotic lifestyles are not included in the programme. There's 25% opt-out, which could either mean they're getting good family support or they're opting out for negative reasons.
Yeah,
and I'm just wondering why, if we're joined up, that we're investing all of this money in family nurse partnerships, the involvement of the midwife, the involvement of the health visitor, etc., etc., etc. And how did we come to evaluate that as a better model than investing seriously in some of the service providers that we heard at the earlier session? Who made that equation?
Well, could I just sort of recap on some of the things you've said? What we presented was that as part of implementing the programme, the stretch goal is to have at least 75% of those offered the programme taken up the programme. And I'd already...
25% would.
Well, if I just explain that, at least 80% of those offered the programme take it up. For the ones who don't take it up, there's a number of reasons. They don't necessarily refuse the programme. They may have had a miscarriage. They may have chosen to terminate the pregnancy. They may have moved out of the area, as Sally said. They may have taken up employment.
Reasons.
So the majority of the reasons are not that they have actively refused the programme because they don't want it. Some do refuse the programme because
How much
they feel
for
they've
negative
got...
reasons then?
Well, it depends what you mean for negative reasons. If you're saying they don't want the programme because they don't feel that they'll benefit from the programme, the percentage of that is probably less than half who refuse the programme is because they feel they have enough support. The ones who don't take up the programme because of all the other reasons, I'm not sure I class them as negative. So, you know,
I'm just trying to get a contrast, because you're painting a picture here that everybody who says no to the programme is getting equal or better support and doesn't need the support. So I'm just trying to get a contrast. We've finally got to a stage now that about 10 or 15% disengage.
Well,
for unknown reasons or good reasons.
Well, we do capture the reasons why clients choose not to engage with the programme, and as I say, there's a number of different reasons for that. It's not because, you know, partly it is because they choose not to go on the programme. It is a voluntary programme. It is we offer them as something that's they're eligible to receive, and the majority of people do take it up. And actually, in comparison to the engagement with other services and other programmes, both in terms of initial engagement and sustainability, it's actually
what I'm trying to get at is if those people who are positive and responsible and they've got their partners' involvement are involving themselves in the scheme, would they not be getting good outcomes anyway, irrespective of the family nurse partnership?
Well, I think that's an interesting...
Why do we need the family nurse partnership to make it better? I'm just trying to make an evaluation.
Yeah, I mean, I think, you know, there's a range of people who go on the programme, but the majority of them do come from deprived backgrounds. They do have at least 2 or more other vulnerability factors that make them vulnerable. They're already vulnerable because of age. And in terms of those that engage, we're giving the children who have the least chance in life, giving their parents the greatest potential to make a change in those children's lives. So that's the reason for it. In terms of why they're engaging with it, then, you know, I think the answer is, you know, the evidence shows that actually by engaging the programme, they will get better outcomes, and so I'm not sure which outcomes
we certainly visited a very good project in Glasgow, which they're struggling to support and fund, and it looks as if it's doing the trick. And I think there's a similar experience in Dundee. It's actually helping young mothers in that, keeping them in education, looking for those outcomes, struggling to fund that in the local authority base. Why are we investing in family nurse partnerships when the outcomes will not be any clearer? And why are we not giving more money to those people in those school projects that are struggling for money and could support even more young women, but the money's not there? Why would we support family nurse partnerships as other alternatives? I mean, you know, if there's a good reason, then I'm happy to hear it.
It's actually in the current government's manifesto, and it's also it's a licensed proven programme. So I think I was actually invited to the Finance Committee when we had this debate, and apologies if I've not got all the evidence to... I can start to give you some, because I thought this was more about teenage pregnancies. I thought that was my role here today, about prevention of teenage pregnancies. But I think there's been a lot of debate and a lot of scepticism, even within Lothian, when we were the first pilot site, even across our own professions, about what is the added value of this. We're not America, we are providing a health visiting universal service, therefore why can we not intensify that? There are big differences between what this programme does and what our health visiting service does. Our health visitors have caseloads of around 350 kids in Lothian. Not all as vulnerable as maybe some of the children on the family nurse partnership, but nonetheless ranging from 0 to 5, not just 0 to 2 years. So we're not really comparing like with like. Now what I can say is from the first and second evaluations, the outcomes that we've got, I'm not convinced, but without doing some kind of randomised controlled trial or some comparison with another cohort, could you actually say that you could not replicate those outcomes with a universal service? Because there's so many variables involved. But what we do know is, even speaking to these young people and seeing the ones that are going on to, a lot of these children are children, they're sort of 15, 16, 17-year-old, were leaving school not having ticked the positive destination box. At 18, they're entering nurse education, nurse training, so there's a lot of stuff that's beginning to come through that aren't collected in the tick boxes that I think really needs to be examined. And from, I think it was January 2010, we started including some of these families in the Growing Up in Scotland longitudinal study. So I think when we start to examine that, we will have more of a feel for, is this really making a difference? Because I think we don't absolutely know. We know that certain outcomes are improving early doors. So if you take breastfeeding, conversion rates, so young kids, 15, 16-year-old who didn't want to entertain the idea of breastfeeding, we've actually seen a 33% conversion rate in breastfeeding. So they may not maintain it and achieve the heat target of 6 to 8 weeks, but they're actually getting that skin-to-skin contact with their baby at delivery. And even though they only do it for 24 hours, they're as proud as punch. So there's little things like that that are beginning to come through. So if we chose to divert the money elsewhere, that's a decision for government and Parliament and the senior civil servants to decide, is it the right use of money? But what we're doing in Lothian, and we're just about to enter our second cohort, is deliver the programme as we've been requested to do it as a licensed programme. And hopefully what we're doing, and we are now working with universal services, and for me it's other little small things like maintaining a tenancy. A 16-year-old getting a tenancy before FNP was sort of the protective factors that brings and how they work with the young person and their wider family. We're seeing children that are able to actually maintain a tenancy at 16 to 18 years of age that may previously not have. That's not to say they wouldn't have, but we're actually seeing they've got a much better support mechanism around them and they're becoming more resilient. I'm not suggesting you're not doing a good job. I'm just, what is the difference of the job that the people that we've engaged in, the people that we've visited in, we're rolling this out across the country and it is very expensive, it's been pointed out. And, we have people on the ground working to these objectives that are very similar to yours. And, as I said earlier, there's a lot of people working in this field.
I think from our perspective, the cost is around £3,000 per year per client for the duration of the programme. That is what the cost is. So in terms of expensive, I suppose it depends how you add that up. The cost of a special care unit for a baby delivered early, the cost of care if the child is given up for adoption, the cost of, a whole range of health, particularly health things and education things that mount up that can be balanced and offset against the cost of FNP.
Negative outcomes, but Smithycroft that we visited, keep young women in there, their health is looked after, they are not delivering early, they are engaging in education and whatever, they are meeting all of these outcomes. How much does it cost to deliver that programme? Is it that programme should be expanded? That's too much on it. Yeah. Nanette Millen, followed by Mark.
I was just interested, I don't know if Caroline can answer, what's the human resource implication of the Family Nurse Partnership? And how many family nurses have been involved in the pilot projects? How many do you envisage being needed as it rolls out over Scotland, and do you think it is sustainable into the future?
I think there's a number of things in there. The Family Nurse Partnership is about developing specialised roles in nursing and nurses with specialised skills to support these young women to maintain outcomes over time. So the outcomes are sustained not just short term but much longer term outcomes, and there's a lot of evidence around that, and I think that's where the power of the programme is, that it does demonstrate that. In terms of the number of nurses that we have just now at this point in time in the programme, we have 58 nurses on the programme. By the end of this year, we'll have around about 70 nurses. And if we were creating a sustainable programme where the programme was offered to every eligible woman in Scotland, we'd have around about 360 nurses. In terms of maintaining that, because the demographics of these nurses are around just over 50% of them come from generic caseholding health visitor backgrounds. We are working very closely with the Nursing Directorate, the workforce planning people to look at how we can sustain that and how we can develop that workforce without having a significant impact on the universal services. But we're not rolling it out in a big bang approach. We have taken a very gradual approach to this, not least because we've had to learn as we go along how to implement an evidence-based parenting programme or evidence-based programme well with fidelity, which is actually quite different to just delivering an evidence-based programme. So we've had a lot of learning to take on board, but also because it is a licensed programme, we actually can't roll forward in that sort of big bang way and roll it out to everybody in the next year or so, for example, because we have to abide by the licence and demonstrate that we are getting the outcomes that are expected from the programme, looking where we might want to make adaptations or augmentations if those outcomes are not being achieved, but also working closely with the licensed developers to make sure that the programme is being implemented well.
That's helpful because I do have a concern about the sort of universal, the general nursing service, given that we've, a lot of nurses are coming up for retirement and there's been, perhaps a cutback in some of the nursing services. So that's useful information to have. Thank you.
Martin McDonald.
Yeah, just an observation rather than a question, Convener. I think I would be reluctant if we were to look at this as family nurse partnerships in competition with other work that is going on. I think that certainly the evidence we received when we went to Dundee was that they're complementing the work that is going on, not competing with it, and that was certainly the message that came across to me. I think the other point to make as well is that I think the point that was made by Carolyn Wilson about the sort of the on-cost, I think it was maybe by Sal Egan, about the on-costs that you would have were these interventions not taking place. I think that people may look at the programme and say that it's an expensive programme, but there's also the question as to whether or not that's a price worth paying when you look at the potential costs that might incur otherwise. So I just wanted to put that on the record.
Thanks for that, Mark. Richard.
I don't think anyone's debating the efficacy of the FNP programme, and I don't think, Convener, you are doing so either. I think that the long-term outcomes, I think, justify us going ahead with this, and we'll see what the English trial shows. But the concern, really following up from what Nanette Milne was saying, is given that this only applies to people before 28 weeks, and that there are this particularly vulnerable group who present late and will not be eligible for that programme, if we're taking 175 health visitors out of the system in the next 2 to 3 years, you're not going to be training these people very quickly. In fact, we're not training more health visitors at the moment. We're training very, very few health visitors. So the impact upon the universal service, which has now to deal with the most vulnerable group, it could be highly negative. I don't want to go down here as being perceived as critical to the FNP programme, but I do want to see that we make sure that this particular group of vulnerable young people who are the teenage pregnancies who are presenting late are not going to actually suffer, and that we've got programmes in place for them which may not fall within the licence but provide similar services with similar intensity, because they are the most vulnerable group. And then finally, of course, the universal services, what will actually happen to them if we take, it may be Carolyn Wilson can give us the workforce figures later. If you take 175 health visitors out of the programme, and given, as Nanette said, that the age group is above the average, there are many more in the later in their career than in many of the areas of the profession, what effect is this going to have?
mean, I think, as I've said, we are working very closely with our nursing colleagues in the government, with the workforce planning people, and we're not going to make decisions that have a very big impact on the universal services without taking into account all the other factors. I mean, one of the, well, certainly since I've worked in the Family Nurse Partnership Programme, there's been a piece of work about modernising community nursing, but there is a strand of that is being taken forward just now, which is looking very closely, particularly at the health visiting and the school nurse role, and in terms of how they can work more intensively with younger groups or more distinct groups of families rather than the public health nurse approach where they work across the whole of the age groups. So,
yeah, but, I'm sorry to interrupt, but I mean, we've cut the nursing student intake by 20%. We've reintroduced a 36-week universal health visiting test because, I mean, our Conservative colleagues were very concerned about that. And I think quite rightly that we were losing really quite considerable pickup on that. So, you know, we've got a cut in the intake, we've got an additional burden upon the health visitors already. I'm just really concerned that we're going to have some major problems going forward.
Can I just add one more point? Just, and I totally take on board your comments. Certainly, in terms of the evidence so far in the areas we've implemented, it's not had an impact on the universal health visiting service. Every post has either been replaced or the services have been reshaped to take account of the reduction in the number of generic health visitors. As I say, going forward, it's something that we do recognise and we will take cognizance of going forward, and we're not going to move forward with a programme that is going to have a very detrimental effect to the wider health visiting services. I don't lead on the nursing services or the workforce side, so I can't really make much more comment than that. I'm sure Sally could perhaps give some information of what happened locally in Lothian, but we're confident at the moment that we're keeping pace with maintaining the services that are already there.
Thank you.
Yeah, I mean, I am a nurse by profession and a community nurse, so I can speak with some sort of authority on this. I think there are concerns across Scotland, certainly within the Royal College of Nursing and Royal College of Midwives. I'm not speaking on their behalf, but I do know their views in terms of the impact on community nursing. And within Lothian, within our wider children and young people strategy, we have a workforce plan. Now, I have got concerns, both very short-term and longer-term concerns, as how we maximise the workforce. I've been fortunate to secure out of our health funding additionality into the health visiting service for next year, and that's to support the introduction of the 27-month assessment and the population rise in Lothian of all children. We heard earlier about school nursing and how do school nurses, and given their ratios, the ratio of school nursing is the desired in Scotland is 1 to 1,700 people of a qualified public health school nurse. In Lothian, our ratios are 1 to around 2,300. So for our school nurses to take on very much more is going to be very difficult. And as we heard earlier, there is, over the next 3 years, we will see almost a doubling of the childhood immunisations from preschool right up to S3. So there are implications, both at local level and at national level. And at national level, Ros Moore leads that work, and Deirdre McCormick, the nursing officer, has been heading up a group looking at modernising the health visiting workforce and the school workforce, with a recognition that actually they're very two different professions now. We tried for years to say it was one public health nurse, but the jobs that they do are quite different. So within Lothian, we've been training an additional 6 public health nurses each year. It had been down to 4 about 3 years ago, but when the FNP came on board, we have been fully funding on whatever band. If they're on a band 5 or a band 6, we fund them on their substantive grade through Queen Margaret University College. So each year we've got 6 qualifying, but we do recognise that we're actually seeing, a number of people are choosing, they don't need to tell us 5 years in advance when they're going to retire, so they're taking age retirement at 55. So we have to really keep on top of the workforce plan. And as well as that, we're also looking at what other professionals and support workers can we bring in? We're looking at maternity care assistants, we're looking at health visitor assistants, nursery nurses. How can we work more with the voluntary sector, work with agencies like Sure Start to produce some of it, to provide some of our early years services? How do we redesign the caseloads? But it's part of a wider early years workforce issue. We've also got issues around community paediatricians, so we can't just look at the public health nursing workforce in isolation. So I think just to reassure that certainly at local level we are looking at this, but I think it's fair to say that if we aspire to deliver what we've said in terms of early years, then there needs to be a workforce skill and capacity to do that.
I've got Bob first and then Drew. Thanks. Bob.
Just to return again to the targeting nature of family nurse partnerships, because I think the convener was alluding to concerns that some of the most vulnerable may not be captured by family nurse partnerships. But my understanding is by its design, it targets the most vulnerable. I just want to just clarify that I've got my understanding right. First of all, if you have a child and you're under 20, you are more likely to come from a deprived area and be vulnerable. Is that correct? Right. In terms of the attrition in the scheme itself, in the last evidence session we heard evidence that you're more likely to be from a non-deprived area and refuse assistance from family nurse partnership. Is that something that you've got information on as well? So you're less likely to be vulnerable and refuse?
Yes.
Right.
So, yes, that's correct. We know that, as I said, that at least 75% of first-time teenage mothers are from the most deprived backgrounds. So if you look at 100% of the people we're offering the programme to, and 25% don't take it up for one reason or another, and actually it's closer to 20% don't take it up, then actually the proportion of them who are more likely to have higher levels of vulnerability is a lot less, because by definition most of them come from deprived backgrounds and have more vulnerability factors. Okay. So I mean, we do have information, and as I said before, they're more likely to come from more affluent areas, but that doesn't by itself mean that the individuals are not deprived, because teenagers, unless they're millionaires, you know, they don't have a lot of access to benefits, particularly if they live in a household where you know, and they're under a certain age, under 16 specifically, they don't really have access to any benefits for themselves. No. So, you know,
I think we need to be careful too not to make assumptions, because people can be vulnerable in different ways. Inequalities is a large part of it, but I certainly know of 2 girls within FNP who came from very, what one would describe as affluent backgrounds, who their vulnerabilities were probably tenfold most of the kids on that programme. So this is why I don't think we should make assumptions that because somebody lives in a nice neighbourhood and their parents drive 2 cars, that everything in the garden's rosy. That person has still became pregnant, it's still been an unplanned pregnancy, and still maybe needs support, and there may be other factors around that person, because it's not just about the pregnancy, it's the wider holism around that whole assessment process.
No, sorry, yes.
Sorry, I was just going to say, we've certainly got evidence on that for clients who are in the programme. The challenge is you can't get a lot of evidence for people who don't take up the programme, because you can't collect that data and keep that data on them. We can only get very high-level demographic information on them.
No, I think I should say that the reason for asking this and what you've illustrated is the need for the integrity of the programme to be universal, because you can't identify where the vulnerabilities are. But I was really teasing out the point that they're predisposed to be more likely to be vulnerable in deprived communities, and the uptake is more significant in deprived communities by definition. So there's a form of targeting, but the universalism aspect of it is important to make sure we capture all need, irrespective of where young mothers stay. Now, the convener did raise I thought, a fair point in terms of those who can't access the scheme, again, because of the integrity of the scheme, where you have to do it under licence for what the evidence base proves works. Is it after 26 weeks?
28 weeks.
Okay, so it's after 28 weeks. Now, we can't be talking about a huge amount of numbers, so I think it would be helpful to the committee to get some of that quantified, so we just know the numbers we're talking about. And in terms of whether or not there is strain on the system in terms of nurse provision, I think it would be reasonable for us to make that case perhaps elsewhere in terms of workforce planning to make sure there's a surety around that. But just for the record here today, you've not seen an additional strain on the system because of family nurse partnerships. You're meeting all your current statutory and policy obligations as well as family nurse partnerships, or are you not? That's what we just have to clarify, I suppose, as a committee today.
I mean, we will be recruiting for the second cohort, second team of nurses in the near future. It will be a national advertisement that will go out, so we won't just be recruiting from Lothian, but it will have an impact. We will need to look at how if the people who were successful in being appointed came from health visiting, it would have an impact, and we would need to manage that very carefully. If all of the nurses came from Edinburgh, say, the chief nurse would have to look at how she supported that. And obviously, as I say, we've got nurses qualifying come June, July. We're training 6 health visitors at the moment, but we can't predict for people who just decide, well, actually, I'm going to take an aged retirement. You could have 2 or 3, you might have none. So we're planning as far ahead as possible, but, you know, it's not even in relation to family nurse partnership. It could be any reason, you know, that somebody chooses to leave or move on. It's a very vulnerable workforce, I would say, public health nursing, because there are certain things that only the health visitor can do. And as I say, next year is a very important year because we're reintroducing the 27-month review for all children, universal, and we're also upping the immunisation programme. So for both health visitors and school nurses, there's a big impact next year.
I suppose I was just trying to tease out the point, and I won't come in after this. I know Mr Smith's wanting to come in, is that we're talking about a workforce management issue rather than a resource issue. That's what I'm trying to tease out, because there'll always be peaks and troughs in terms of early retirement, in terms of nurses deciding to take a career path into one discipline rather than another, and workforce planning has to be attentive to that. So I'm content that will happen, and this committee can always check that that's happening, but it's a workforce planning issue as opposed to a resource issue, as opposed to what I'm trying to clarify.
It's a resource issue at the moment. If you've not got the people trained up, because to become a health visitor, you must be a registered general nurse and you must do a year postgraduate at a university for a public health nursing degree. To be a family nurse, you don't necessarily have to be a health visitor, so there's more of a pool of nurses that you could pull into FNP training than what there is. You can't just put anybody who's qualified as a nurse into a health visitor job. So it's a little bit, it's a lesser resource out there to pull on. So as much as the workforce planning is important, the resource, there isn't a human resources out there across Scotland possibly to fill all the posts.
I suppose that's what I'm talking about, resources at cross purposes perhaps. I'm talking about resources in terms of you have the resources to advertise the appropriate posts, which then feeds into the wider workforce planning. Yeah. Right, okay, so the financial resources are there, it's about how they're deployed in a strategic way.
That's correct.
Right, thank you.
Drew Smith.
Thank you, Convener. I just wanted to briefly return to the issue of school nurses. And I suppose my question really goes around, because I think in both sessions today, when we've discussed school nurses, we've kind of thought about, in terms of some of the proposals that we made to us in written evidence of the role that school nurses could make, firstly around contraception, but then there's also an issue about how school nurses are involved through the family nurse partnership of supporting young parents who are still at school, and what the linkages are there, and if the challenge that seems to have come back is said, well, but there aren't really enough school nurses to do that, to do that as well as we might like. Therefore, we don't think school nurses would necessarily be the route to go. I just wonder, from your experience both of FNP and in general, what actually is the expectation of young people themselves about whether or not they want a health service or a health-related service delivered at school and through a school nurse? Because that seems to me to be the more important question than whether or not we have enough of them, and whether or not we support them, and whether or not they're talented to do the right thing. Because if the demand is there, then surely we would invest in it. Because the suggestions been made to me that for some young people who, on the issue of contraception, they might say, well, I don't particularly want to go to the GP for a range of reasons. One very simple one might be that the service is not available at the time that I can go there because I'm at school. in that time, and therefore you think, well, school would maybe be a reasonable route to go down. What understanding do you have of where the demand is from young people?
I mean, I think the demand is there, and our school nurses tend to work in the drop-in centres because, as I say, they cover more than one school, so they wouldn't be sitting in one school easily accessible to a pupil. And I think, you know, I would have to check what's been gleaned locally, because we do a lot of children and young people involvement across the 4 Lothian partnerships and in health. But many children don't want to do things within the school. They would rather go somewhere else as long as it's easily accessible. And that's sort of anecdotal, what they'll tell you, you know, because of confidentiality, etc. Some children won't be able to tell you who their named school nurse is. You know, it's not their named person under GIRFEC, because that's the head teacher, because it sits within health. But some schools would be able to tell you who their named school nurse was.
I suppose my real question is, and I'm going to leave it there, convener, because you know, I think we've heard about it, you know, and I think we'll continue to hear it through this inquiry. But is it worth finding out? Because what we're getting back is anecdotal on both sides of, you know, I don't want to necessarily go to the GP, but also I don't necessarily want people at school being involved in my business in this way. You know, given the amount of money that is involved and the level of priority this is, shouldn't we just go and find out? And that data should be taken through the programmes that are already existing about what actually young women's needs and demands might be.
Yeah. I mean, I think we could find that out, and it's maybe something that's worthwhile. There was a piece of work, government-led work, about 5 years ago in relation to healthcare in schools, and it looked at the whole issue around school nurses, what they did, what was needed, who else was needed to support the programmes. Now, that work did come to conclusion, but in terms of the recommendations from it, I don't think there was ever an implementation plan came from government around that piece of work. And I know there was pilots, because one of them was West Armadale and West Lothian, which looked really at bereavement, what children who'd either lost a parent through death or, you know, parents moving on, relationship issues. So it focused on that, and there were 4 pilots in Scotland that looked at the role of sort of school nursing and what it actually brought to the wider education. I know that if I speak to my education colleagues, head teachers, they really see the value in having the school nurse and knowing how they can contact the school nurse if they're looking for advice. But the school nurse isn't always available on site, and the kids in the school who maybe associate the school nurse in secondary more around getting their immunisation for HPV or other immunisations, they may not actually think it's somebody they can go and talk to because they're not there, they're not on site. Some schools, I think, have auxiliary type workers who children may think is the school nurse that they go to if they need something.
The piece of work was the health and wellbeing in schools work, and it was also looking more broadly at where children want to access some information around health and wellbeing. What was the best model for moving that forward? And part of that, I think, informed some of the curriculum for excellence work, but also looked at wider non-professionals, so paraprofessionals coming in to deliver some of the services. And as I say, there was 4 pilot areas. There was quite a bit of investment from the government, but as I say, I'm not entirely sure where that stands just now.
Recommendations went from that particular piece of work.
And any other questions? It's just one final one in terms of the context that we're working on. Just at the end of the last evidence session, I think somebody mentioned the report about, you know, the sexualisation of young women, and the government sponsored that report. And I was just wondering how that influences the general work in this area, because we're engaging with people who are dealing with the consequences of risky behaviour or poor decisions. And, you know, this morning, and indeed as a significant part of our inquiry, we're dealing with that end of it. How do we support young mothers? And so how is that? How did that report in 2010? Are you aware of the report? I think you were here earlier.
I am aware of the report. It didn't necessarily inform the Family Nurse Partnership Programme, the element that I'm involved in. I suppose what's more informed that programme, and what's still informing the Family Nurse Partnership, is the emerging evidence about the adolescent brain development and how adolescents make decisions, and how that then informs some of their reactions and connections with what's going on in wider society, so sort of peer pressure, you know, how they react to societal norms, how they make decisions. So that's the sort of evidence that goes into FMP, as opposed, you know, we do take recognition of the other work that's going on, but we haven't looked specifically at that element of it.
Yeah, I was just, you know, I've taken the message that we're all working in partnership with this. You know, you're not a standalone. And I was just wondering whether that report in general had influence of what the government's response was to that report, and whether it could inform the committee in its subsequent inquiry and report.
Yeah, I certainly think some of my colleagues in the child protection and in the getting it right for every child would be able to, sections would certainly be able to respond on that, because I know that they led on part of that report.
Okay, thanks very much. If there's no other questions, can I thank you both for your evidence and your attendance here this morning. Thank you very much indeed. We now move to agenda item number 3, which is our work programme, and we are now in private.